Open this hearing of the Senate Community Affairs References Committee's inquiry into the Support at Home program. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present, and I extend that respect to Aboriginal and Torres Strait Islander peoples here today. The committee will be conducting today's hearing via teleconference and in person. I'm Senator Penny Orman-Payne, I'm Chair of the committee, and I have with me Senator Ruston, and we're also joined by Senators Antic and Whittaker via teleconference. These are public proceedings being live streamed. I'm just going to say live streamed via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It's unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It's also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. And I remind committee members and witnesses who are appearing via teleconference and who are not speaking to please mute your microphones. I now welcome representatives from the Central Desert Regional Council Aged Care and the Australian Regional and Remote Community Services. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been already provided to you. For the benefit of the Hansard record, could I ask each of you to state your names and the capacity in which you're appearing today, and I'll start on my left.
I'm Melissa Clear. I'm the Executive Manager of Community Programs for Australian Regional and Remote Community Services.
Thank you.
My name is Marlene De Silva. I'm the Acting Director for the Principal Programs, Central Desert Regional Council.
Thank you. I'm now going to invite each of you to make some short opening remarks and then we'll go to questions. Mrs. Clear.
Okay. Firstly, thank you for allowing us to appear here today and inviting us to participate in this inquiry and provide an opportunity of an insight for our operations and workings across the Support at Home program. In June 2025, we were asked by the department if we would re-auspice 3 programs in the APY lands of South Australia: the Home Care Packages program, NATSI-FAT program and the residential facility in Pukaja. We also provide services across the Northern Territory in Nhulunbuy, Darwin, Alice Springs, Katherine, Docker River, Mutijulu. For us, it's been a journey, and it's been very true current. For us, it's been a journey, and it has brought the very true, current and extreme risk of being non-compliant, being sent a please explain from the Commission regarding statements, and our imminent audit registration pending next month. Why? Because we deliver services in remote communities. Remote communities where the provision is bloody tough, costs are extreme, community unrest and movement is unpredictable, regular ceremonies occur, clients don't want to or generally don't understand the administrative requirements on a provider, and quite simply where the legislative requirements of individualised funding doesn't work. In June 2025, we were asked by the department if we would re-auspice those 3 programs. We completed the due diligence, distance, remote, community unrest ceremonies, all of which we experienced in our other locations of service of delivery, but there was no support at home in those communities. In approximately 4 weeks, we commenced service delivery, ensuring that services would continue for those communities, and they did. We well understood the home care package legislative timeframes requirements, accepting MAC portal, registering clients with Proto, and all of the administrative processes in between. Within 16 weeks, we're expected to adhere to the legislative requirements of the HCP program, review MAC details, complete assessments, explain agreements, sign agreements, explain statements of rights, sign statement of rights, create care plans, identify risks and ensure the provision fit inside the allocated package level. All of this needed to be done while ensuring no disruption to the service delivery within the 6 communities was made. The meals twice daily, 5 days a week, evening and weekend hampers. We were invited to attend community meetings and we engaged with the then Tilpy Pumper, 16 elders who are representatives of their local community to assist us with this. How and what is the best way for our staff to have those discussions with these clients? How would they like and need this information delivered about budgets, fees and about the changes in the program? We received nothing. We made connections with local doctors and clinics, and those partnerships are still proving strong today. So alongside the above in the 16 weeks, we also had to, before the 1st of November, initiate further discussions with the clients about incoming support at home, explain new program, grandfathering of services, new fee arrangements, create new care plans, sign another agreement, sign new budgets. Respectfully, these people didn't care. They just want their services, which they indeed continued to receive. The department administration was in progress. MAC outlet creation, registering clients with ARCs on Proda. This was still being finalised in December of 2025. Remembering on the 1st of November 2025, the new supported home program had begun. The department administrative processes for these clients were still not finalised, yet the legislative requirements for both programs were expected. As with numerous other providers, we also were implementing a new client management system to support the new reporting requirements under the supported home program. Our first HC home care package claim was in October 2025, a bulk claim for the July through to October period. And in February 2026, we finally made our first claim under supported home for APY. As not all of the 121 identified clients were successfully transitioned, we claimed for those that we could. This was due to, again, the legislative requirements under the supported home program. November to December claim was to be completed. Late claims could, of course, be submitted, but that will require evidence, and it is an extremely manual process. We still hadn't received any information from Tilpy Pumper on the way that they would need this information provided, and we still had incorrect client statements as none of the clients had their residual HCP funding formally recognised on Proda, and it still isn't. With total respect to the majority of the clients receiving services, they don't care about that. They just want their meals, their laundry. They request transport here and there and turn up to the centre for a cup of tea. And as a provider in a remote community, we need to build these strong relationships with our clients, gain their respect, support them how they would like to be supported, provide referrals to allied health, work with existing programs within the area and provide quality care when the client chooses. And we have. We have a damn good team down there that live extremely remote, live in shared accommodation, deal with some really difficult levels of community violence and unrest. They provide quality, safe care and legitimately care for those clients they attend to on the lands. The service level has doubled. We have successfully upgraded 6 of the community kitchens, laundries and created respite centres, and they are being utilised by these clients. We have formed great working relationships with the clinics in every community, meeting with Nanapa Health nurses weekly, providing support and identifying deterioration of those clients. We visit 3 times a day. We also provide 3 hot meals a day now, 7 days a week. How? Basically, it's the thin market grant that got us through. We were successful last year, and that we are so grateful for. The extreme costs of freight, staff, rents, food, upgrades to support the services we were providing. The law, 2 staff attending at all times. What client quarterly budget would accommodate that? Without that, under the Support at Home, individualised funding is not viable in remote community. Hopefully, we're successful again in round 3.
Thanks very much, Mrs. Clear. Mrs. De Silva.
Thank you, Chair and Senators, for the opportunity to appear here today. So, Central Desert Regional Council delivers aged care services across 9 remote Aboriginal communities in Northern Territory, including Amadjira, Atijra, Ingwala, Lajimanu, Loramba, Niripi, Villara, Villora, and Yulamu. These communities span more than 282,000 square kilometers and are home to elders who speak multiple Aboriginal languages and have strong cultural obligations and shape how care must be delivered. Our experience is that delivering aged care in very remote communities is fundamentally different from delivering services in metropolitan and regional areas. Our older people want to remain in their communities, close to families, culture, and country. To make this possible, they need reliable and culturally appropriate services that allow them to live safely and within the dignity at home. One of our key concerns with Support at Home is ensuring that the funding and pricing arrangements recognize the cultural actual cost of remote service delivery. Distance, small client numbers, workforce shortage, staff accommodation, transport, food and freight cost, limited local suppliers, other overhead costs such as electricity, water, and access to allied health and clinical services all increases the cost and complexity of providing care. We also operate in thin market. In all remote communities we are serving, there are no other alternative service providers. If a service becomes unsustainable, an older person may not simply have another provider they can turn to. We are also concerned that co-contribution could become a barrier for older people experiencing financial hardship. Cost should not prevent someone from accessing the support they need to remain safely at home. Our message to committee is that equal funding does not necessarily produce equal access in remote Australia. We encourage the government to consider a remote-specific funding approach that provides greater flexibility in service delivery, recognize the true cost of maintaining services in thin markets, and reflect the culture and geographical realities of very remote First Nation communities which differ significantly from urban settings. Our aim is to ensure older Aboriginal people can continue to live in safely and with dignity in their communities, connected to family, culture and country. Thank you.
Thanks very much, Mrs. De Silva. I'm going to go to Senator Whittaker, who's going to kick us off for questions.
Thank you very much for appearing before the committee today and for the work that you do. It's important work around the country, but it's particularly important work in the kind of remote areas that you work in. So I want to particularly note that. Thank you for your opening statements. It was a really good insight into some of the particular challenges that you face. I'm wondering if you could both talk to some of the workforce challenges that exist in remote communities and the impact that has on the ability to provide the care.
So I would like to start. So workforce issues means that we know that we are mainly depending on the community members as the staff, which is good because then they can actually talk to the clients with their own language. But having said that, due to various reasons that already Mrs. Claire mentioned, the funerals and fightings and whatever so on, so the people don't normally turn up. So what we had to do is we had to sometimes depend on non-Aboriginal people based in communities. So finding people to go and stay in community is the major issue due to the lack of accommodation or the conditions of the accommodations, or otherwise the situations depending on the communities. So this is what actually main staff issues that we are facing with. And we are unable to actually run a center just only with one staff. We always need at least additional staff. And these actually contribute to our overhead cost. So sometimes we might have 1 or 2 staff to run the center, but then there might be no clients in the center community at that day. So with the new Support at Home program, if we provide a meal, then we get money. But if you don't provide a meal, then you don't get money. But then having said that, we have to pay for that person on that day, because we cannot have casual staff in community. We can have only part-time staff, because calling them in the morning to come to work, it's not going to work. They're changing their phones every other day. So we have to have reliable staff who are coming daily to work. And since that not like, yeah, so I'm happy to, this is the workforce issues that we have, and finding qualified staff, because we know that we need to have qualifications. And that is another issue with that, because providing training for the community members are really difficult. They are not normally going to come to Alice Springs for the training. So we have to send the trainer to them. But just to provide normal first aid training in community, they will be charging around $3,500 to $5,000. But some days, if you when the trainer goes, if that is a day that is not suitable for community, if they're having a funeral, most probably if it is funeral, yes, we can actually organize something. But if it is a fighting, then we don't have any control. Then the trainer will be coming back, but still we have to pay. So having qualified people to serve, it's another challenge. And this is a cost that we have to send another person again on the next day. So these are the challenges that we have with the workforce.
Yeah, we have similar. Again, we try to work with and we are working with the community in regard to supporting a local workforce there as well. We do have those issues again where they work for a few days and don't turn up. We are promoting traineeships, but again, it's the probity checks and that sort of thing, the licensing, all of they all pull against what we're trying to achieve out there as well. We rely a lot. We have a heavy clinical focus in our workforce. We rely a lot on agency nurses, which makes it extremely difficult with the training again, the transient, trying to maintain that efficient documentation that we're required to have, explaining to them, because a lot of them aren't community nurses that go out there. They're residential nurses that haven't had a lot of experience with the requirements under the supportive home program or the older programs where we're required to collate all of that information. Again, now also with care management, clinical care management, that has to actually be documented and claimed. Otherwise, we miss out on that funding again. And that again is hard to train the staff coming into the areas.
Thank you. Have either of your organisations benefited from the SIM market grants that the government offers?
Yes, so our organisation actually, we were benefited from the second round, and we applied and we received the money. And we are hoping to apply for the third round as well. But the issue is that, we have limited number of clients under home support program, support at home at the moment, because we are actually doing Commonwealth home support program, as well as we do have Natsiflexi in few communities. So therefore, I am unable to clearly say that, that has been really benefited for us, depending on the amount that we have received. But having said that, daily, the cost is going up. And if we need to send someone to a community for an emergency or the coordinator leave, then we have to send someone from Alice Springs. And minimum, the closest community is 200 kilometers away. The furthest one is 890 kilometers away. So with that, sometimes a person is just traveling only to reach the community. And then we can provide the services only on the next day. And having said that, we don't have much other providers in community. And also, if we ask someone else to provide, then the cost that they will be charging us, like if we ask the store to provide anything, then that will be a huge cost that they will be charging us. So therefore, yes, we have applied, but whether it is substantial, it's really difficult to say at this moment, because actually we are not only depending on that support at home program itself.
Yep, we were successful also in the second round, and I believe that's the only way we've been able to remain viable currently under the situations. It excludes, as Mrs. De Silva said, it excludes anybody on a wait list or a wait for a package. It also excludes those people that are coming through the system that have been assessed to receive CHSP meals, for instance, in an area where there's no CHSP meals. So there are a lot of clients and upcoming clients that we know will come through during the year that will fall through those gaps.
Thank you. Much of the evidence that we've heard, and certainly the submissions to this inquiry, have supported the kind of broad intention of the Support at Home program, but have talked to some of the challenges in implementation. What's your view on the intention of the new program and what it seeks to achieve? And do you think that the Support at Home program, if it were to work well, would deliver better outcomes for older Australians in remote communities like yours?
Yes. In our area, I hardly doubt that whether the Support at Home program will be viable. The reason is that we will get money if we provide a service. But the problem is we do have a cost that without even sometimes provide any services. So if we are unable to, as organization, if we are unable to cover that cost, then I'm not sure whether the Support at Home program is the right one for the community. But for us to see whether this is going to be viable, then definitely client contribution need to be really looked at. Because at the moment we are charging only for the food, because we cook and we provide the services, or otherwise we wash the clothes and we then take the clothes to the houses. And even that, it's really difficult for us to actually claim from them. So the clients will sign the Centrelink form and they go home and they cancel it. It might be the client's wish, or it might be the family member's wish. But having said that, as an organization, it is a loss for us. But if they don't pay, that doesn't mean that we can actually double charge from the next time, because they will not have additional pension money on the next time. And also that we are looking after only meals sometimes. We are not looking after the whole thing. So then client also need to have money for their other things. So therefore, when you look at that, it's really difficult to say at this time. But frankly to say, we have not taken any new clients under Support at Home at the moment for Central Desert Regional Council, because we have some CHSP as well as NATSI balance remaining. We are actually working with the assessors to see that people come through that, because otherwise it's really difficult for us to explain two members who are in the same house why one person has to pay, why the other person doesn't have to pay. And whatever the language that you try to explain, I don't think that they will be getting it. So as long as that, the home support program and CHSP as well as NATSI is there, we are trying our best. But we do have home support clients under grandfather client where they don't have to pay. So that is how we are at the moment doing the services for the clients.
Yeah, okay, that's useful to know. Do you have any clients who have
Can she hear
been
me?
successful?
Excuse me, Senator Whittaker.
Yes?
Mrs. Clear would just like to give you an answer as well for that question you just
apologies.
asked.
My apologies.
That's all right. I don't agree that the individualised funding supports remote communities. Too many people fall through the gaps. Too many people we support under NATSI now that we're not funded for. New clients coming through that are referred, they're not going to pick up the support. And then, as Mrs. De Silva said, they're not going to be grandfathered. So the people in that house are going to be having to ask to be paying a sum of money, and they're not. And I believe we could provide better outcomes for the whole of the community with block funding. We've applied actually under the pooled program that's occurring currently at the moment. We haven't heard about that yet, but in our experience down there, we could provide far greater services for more of the community under a block-funded program down there.
Thank you. Have any of your clients successfully applied for the financial hardship provision?
Central Desert has not applied yet because we don't have actually new clients under home support program, but we are planning to apply.
Say that. Sorry.
Yeah.
We have identified there's at least half a dozen of our clients requiring to pay currently. I believe it's due to paperwork not being submitted, but again, now our staff are supporting them to complete the processes that need to be completed there.
Just a final question from me, Chair. One of the things that that the government has announced from the 1st of October is that there'll be no contribution for showering, dressing and continence management, so those supports will be fully funded. Do you think that goes some way to addressing some of the issues that you've talked to regarding cost for clients?
I don't. Then it's another discussion to explain to the clients that already aren't understanding what's happening or occurring with funding, without funding and all of that sort of thing, whereas we're already offering currently at the moment, and it will impact those new clients coming forward that are currently on wait lists, but as their grandfathered clients currently, it's not going to impact the clients that we currently have.
To my understanding, the main services that we are actually providing is meals, transport, laundry services, and center-based respite. And I think still they will be affected by this new support at home. So I know that personal care will be going to the other side, but then again, the main things that they actually are providing is this, because most of them are actually either malnourished or otherwise they have some kind of a chronic illnesses. So therefore their meals need to be properly managed. And the other thing is the transport and also laundry services, which they don't have much. But still, this is they have to pay. So I don't think, and even if they don't have to pay, now the problem is it's not that client only paying. The thing is that who will be paying us if there is no client in the community? Who will be paying the staff? And who will be paying the rented cars that we are having, because we don't have our own vehicles, so then we have to lease the vehicles, and then the electricity and the water or the lease agreement that we have with the CLC. So these costs, how that is going to be covered if it is not a block funded?
Can I add to that? There are other issues. There are other issues in the community as well in regard to privacy in their homes, the respect that they need. We have some clients that do attend the centre, and we encourage them to attend our centre if they require, when they require. A couple do take you up every now and then, and they come down. But other than that, it's a real acceptance. It's a pride as well in regard to acceptance of those services. And again, the number of people living in some of those homes there and the state of some of their bathrooms, it all impacts on the service provision there.
And if I
Thank you. Thanks very much.
Yes.
Yes,
If I may, the thing is that when that is coming to mainstream, that we know that client will ask a service and then we will send a staff to there. And if we send the staff only, that we have to pay the staff and then we will charge from the client. But in our case, every house do have minimum 10 to 15 people inside the house. So culturally, it is not appropriate for us to send someone inside a house where there is males and then the other family members, or maybe due to different other reasons like poison cousin or something. And then these situations that we have to maintain our own centers for the client to be there, or just to have a nap, client to come and just have a rest because they were having fights or anything, at home. So these are the costs that I think that no one has considered when they're thinking about this home support program. Home support program, I think it's really good for the mainstream. Client do have the choice. There are multiple suppliers, but here client doesn't have a choice. And also we don't know how much we can actually increase our price. I don't think that we can charge $1,000 from a meal, but sometimes we might spend $1,000 just for that meal because to maintain everything. So this is something that we would like government to consider. Thank you.
Can I, just following on from that, so is it the case that actually the majority of the services that you're providing tend to be provided away from clients' homes, even if it's individualised care?
Yes, because the thing is that if we have to provide them personal care, they don't have a bathroom, so where to provide this personal care? We have to bring them. And then if you go home that, they don't have cooking utensils, or if there's anything that is broken, or the laundry washing machines are not working. So that is what we do. We bring the client in the morning, and then we provide the services, and then we drop them. So if we have 10 clients, then we will make sure that 2 clients every day that they come and they can have a shower, they can wash their clothes, and either we will wash them depending on their capability, and then we will drop them. So this is the majority how the service is actually delivered in very remote communities in Central.
Is it the same for you, Mrs. Clear, for your service?
Yes and no. Yeah, the majority are away from the client's home, but we do provide domestic assistance, we do provide yard maintenance, we do provide all of those things as well. So it's a bit of a mix.
So what I'm hearing is that an individualised package, is there any circumstance where you could see an individualised package model working in remote communities, or is it your view that block funded services, whether that be the continuation of CHSP or being able to have block funded other services that go beyond CHSP, is it your view that that really is the only model that works?
If the legislative requirements of paperwork being signed and all of those things weren't involved, it could be managed. But I still believe that the block funded model will support more people, and the more upcoming, which are going to come through the system very soon, it would support them better. The majority of the services are the same. They like the same thing. We can arrange for specialists. We work with the clinics and all that sort of thing if there is a specialised care required, and we can do that. But I still think that you could do that under a block-funded model for the individuals that require it.
Mm-hmm. The government's just announced that CHSP will continue indefinitely. They've guaranteed funding for the next couple of years, but we've certainly heard in the inquiry that came before this one that CHSP has been neglected and underfunded for quite a period of time, probably underinvested in the last decade. In terms of what happens next, would it be your preference to see consultation and co-design around what CHSP looks like going forward as the main thing for service here, as opposed to trying to tweak support at home to fit your context?
I think rather than CHSP, I would say that we prefer Flexi model at the moment, that what is there. But having said that, yes, if you look at the CHSP, you can see that per meal that it's a very minimal amount. So yes, if they can work around, which can be kind of similar to Flexi, that would be really great. But individual packages, definitely, from my perspective, it's not going to work in remote communities because there is no other service providers. There is only one service provider, or maybe, I don't know, but in our area, just only one service provider. So the problem is that for us, if you provide only services, you can get the money. If you don't provide, you can't. And even the person do have 5,000 or 10,000. If the person is unable to utilize that money, and if the organization who is providing services are unable to provide the services due to various reasons, then I don't think that it is actually valuable. But having said that, if there is a block funding, then of course we can actually manage with that. And we can look at the other aspects of the people who can actually get different services, rather than looking at who the only person or 2 people who is having the packages.
Do you mind me asking what the advantage of the Flexi model is?
Flexi model, the advantage was previously that we can do the assessments, and then we can actually start providing the services. But now that is also changed, that it's not like that. But having said that,
Sorry, can I just go to that part? So is it the case now that everyone has to go through the integrated assessment model, even for NatsiFlex?
yes, that has been, it is kind of changing. Now they have added the NatsiFlexi clients also to the system.
And what impact is having to go through that IAT process having?
So by the time that we assess internally and then put forward for the department My Aged Care to assess, and when the assessors try to assess, either person is not in community or we are not eligible to talk on behalf of the client most of the time. And these people sometimes, now actually the assessment has been really good, but at the moment that they started this assessment system, it was really bad. They were assessing from Perth or somewhere else, not in Alice Springs, but now luckily most of the people are now based in Alice Springs, which is good. So it's really difficult and it takes long time. And by the time the assessment comes, sometimes even the person is not in community.
So are those people getting assessed over the phone from Alice Springs? Are there any in-person assessments happening through My Aged Care?
At the beginning, that actually happened from most of the time it's on over the phone, but now the people are based in Alice Springs, so they are visiting communities.
Okay, so they're coming out to the communities to
Yes.
do in-face. So you've got face-to-face, but how long is it taking on average for people to get their assessment?
At the beginning, I think it took more than 3-4 months, but I cannot actually let you know currently what is happening. But I know that the people are in Alice Springs, so they are visiting. I have to check and let you know.
If you could take that on notice, I'd be interested to know how long it's taking on average for people to get assessed. What's the situation for your organisation?
We've had a really good, we've built a really good rapport with the South Australian assessors. They prioritise and they will work around. They know that we have to go and find our clients. We help our clients access the equipment to do that. We haven't had any face-to-face assessments currently down there, but I do believe there is some funding out there that somebody is going to be doing that. I'm not sure at this stage who. The problem is, I believe that it's another workload for staff and unpaid in regard to we can't claim any of that funding. And as I said, then the assessments are coming back due to that algorithm. Yep, approved for NatsiFac and CHSP meals. There's no CHSP meals out there, and the NatsiFac, you're at capacity, but we still provide the meals and everything down there anyway.
Okay. Senator Ruston.
Thank you very much. Can I just get some clarity? At the moment, what are your funding sources for the services that you provide? Maybe start with you, Mrs. Clare.
Our funding is NatsiFac program.
Yep.
Supported home individualised funding.
Yep.
And the thin market.
Thin market. So do you do CHSP?
We have no CHSP funding down there at all.
Oh, okay. What about you, Mr. Silver?
We have NatsiFlexi for 2 communities.
Yep.
And we have CHSP for all 9 communities.
Yep.
And we have home support program as well.
Okay, fine. So I'm just keen to understand. There's been some quite significant changes brought into effect since the 1st of November 2025. I'm just interested in a bit of an overview of your experience of what has changed for you as providers and also what has potentially changed for the people that you care for, particularly given this hearing's about supported home. I'd be particularly interested in honing into what you've seen on the ground in terms of changes since the 1st of November 2025, if any. So it's clear.
For us, it's more of an administrative burden.
Yep.
For the people on the ground, I believe that they're receiving better and far greater services currently. But we're only just new into coming into that service area as well since June. So
what has been the change in terms of the far greater services that people are receiving? Is it because they've had their packages upgraded, or?
No, it's just our insight into service provision and what we believe these people should be receiving. We've upgraded kitchens.
Oh, sorry, no, I understand what you've been doing.
Yep.
And yeah,
as a provider.
Yeah. I'm just interested in terms of your interaction with the government in relation to the changes they've made? I mean, you've said there's a far greater administrative burden. So if you've gone and done all these fabulous things to be able to support the people you care for, how have you been able to fund that?
The thin market grant.
Thin market grant,
Yeah, because we're still having issues in regard to the individualised funding, and finding that funding for our clients, advocating on their behalf for that.
Yeah, okay. What about you, Mr. Silver?
Yes, actually the administration burden. Most of the people who are working from head office, I think they had to just work now additionally, even for the claims. It was not like easier like previously, and going through the new software systems, which we got actually funding from time to time with the software upgrade and everything. But we have made sure that, the on community, like, basically the clients, not to see any differentiation. But having said that, again, I have to say that we have not taken any new support at home clients yet. Not that we have not taken, but we always make sure that we refer them for CHSP or Flexi, because then they will not see the difference yet. But now we thought actually we are going to do that and see how it is going to work, because in case if CHSP changes, because we had the idea that, CHSP might change, and then we had to see the feasibility for the council, because we know that council is providing aged care means it's additional services. But unfortunately, town councils in Alice Springs or Darwin or something like that, we don't get rates from the clients. We get some money from the government, and we are working with that. So we are always working with the fundings. So in case if we are going above, more than that we're supposed to do it, council is not in a position to actually provide this help. But at the moment, actually, we are managing with that, because we were managing from the beginning. Even before this system comes, all our clients were already approved in My Aged Care. So we didn't have to do anything much in that. And even all the CHSP clients was already in the system. And then for Flexi only that we have to add that, but then they were actually added under this client management, the grandfather client wave, not that individual person that we had to refer. So therefore, we did not actually went with much issues on the ground. But then the issue actually happened was at the beginning, that when we had to refer them for the new packages or the upgrade of the packages. Then that time it took long time, but now I can see that assessors has now recruited people, so their people are on ground. So therefore, frankly to say, on ground people did not had any issues. But from the back end, administration part was tremendous. We had to change everything, starting from the policies and procedures and staff handbooks and everything.
So how many supported home clients do you look after in your service?
That's right. We had actually at the beginning 15.
15, yep.
But now we have only 10. But altogether we have 115 clients.
So it varies whether they're NATSIAC, whether they're through CHSP, but you've only actually got 10 that have got the individualised supported home packages.
Yes.
And is that, so your intention, so you've just maintained your existing home care package recipients who've transferred over into supported home for the time being, just so you can get yourself organised and get everything set?
Yes.
What about you, Ms. Claire? How many have you got?
We have currently 112 in the APY lands. We have 200, around 200 in other areas that we support. Supported home.
Yep.
Yes. We have the Flexi funding down there that is of massive assistance for us as well in regard to service provision and doing these things on the land. Going back to that block modelled funding around CHSP, I mean, it's modelled on client contribution, and the client contribution down there is very, very difficult to obtain. So if it was modelled on a block funding like that, it needs to be looked at the high cost to deliver everything down there, the extremes that we deliver, and also there's no guarantee of a client contribution.
Yeah. So what you're really saying is, because of the nature of the geography of your clientele, that individualised personal funding models are less flexible in terms of your ability to actually maintain it.
Definitely.
So does your NATSIAC funding come through as block funding?
Yes.
Yeah, okay. So how, I mean, what is your understanding of what the expectation on you is in relation to your supported home clients around the management of individualised packages as opposed to the block funding? Because if you start moving more towards the individualised packages, I mean, what sort of impacts that likely to have on your service delivery capacity?
I suppose it's more the legislative requirements in regard to the paperwork that needs to be signed, the explanations that we need to, about the funding, the explanations that of client rights that needs to be documented, the individualised budgets that need to be worked out for every single person on the community in the community. It's another body of administrative burden, realistically. Whereas with the NaziFlex, we're able to support more people than we're actually funded for under that model as well.
Yeah. Have you got any, I mean, I know you probably spend most of your time trying to deliver care to the people you care for and not doing administrative tasks, but I'd just be really interested if you've got any data that would be able to probably quantify in any way the difference in the cost to you for the delivery of a service under the NaziFlex stuff that you get from, or even Commonwealth Home Support, as opposed to the cost of the same service in supported home because of the change in how you administer.
I could certainly take that on notice. And,
yeah. I mean, don't spend a long time doing it, because I know you've got plenty more important things to do, but it's just really, it interests me about, we need to make sure that we are focusing on the most efficient model of delivery so that we're actually getting the care on the ground and the maximum amount of the dollar spent in care. And you obviously have just outlined a very different set of circumstances than you'd see in the delivery of care in a metropolitan area.
Absolutely.
Weirdly, outrageously different challenges in that respect. So if there was any way you could get that, you're looking at me as if I've got to stop.
No, it's all right.
Yeah.
We will have to move on soon,
Oh,
but that
okay.
wasn't...
No, that's fine. That was the...
That was listening.
Yeah.
Just to add small thing, I think there might not be much difference in cost. The issue will be that how much the company will be getting. If it is block funded, the company will get the whole money, and even if the client was not there in community, and even if we cannot provide that meal on that day, but we can actually pay for the staff. But if we are providing a meal either under CHSP or HCP or NaziFlexi, the cost kind of the same. But only thing that, what is the return for the organisation to maintain it?
Well, that's part of the story. I mean, you can't ignore that, because it's still it's an overhead cost that you've got to wear. It's sort of also interesting in terms of, you made the comment, Mrs. Clare, that you don't. It was incredibly difficult to get co-contributions out of many of the people that you support. So with support at home, they are legislatively required in terms of, and I imagine many of the people that you're dealing with would probably be on pensions, but even pensioners are still required to make a contribution. So, I mean, like in your experience, what will happen to the people that you look after if they are required to make a contribution? Will they not continue to accept the service, or how will you manage that?
I think they'd continue to accept the service, but how do we get those funds back? How do we get those funds?
You have to wear them if you don't.
Exactly right. So sometimes it's easier to wear them than what it is to chase.
So where do you get the additional money from? Because I mean, if you have a look at the service providers at the moment in this space, I mean, not too many of them are making money. So what happens over the longer term if you are being required to wear the costs that...
Viability runs very low.
Yeah.
Especially in those thin market areas. As we said, it's the thin market grants that's helping, and the NaziFlexi that's actually assisting there. But without those additional thin market grants, it's just not viable.
So it seems a little bit of robbing Peter to pay Paul.
It is.
In terms of, you increase the cost to be able to do something here, at the same time you're having to sort of pay at the back end try and keep you afloat by other means, you sort of think maybe we should get the system working in the first place. So thank you, Chair.
Thank you. That brings us to the end of this panel. Can I say thank you very much for taking the time to actually come and give evidence to the committee. It's been very useful. The committee will report to the Senate on the 24th of November 2026, and we've agreed that responses to questions on notice should be provided by close of business on Tuesday the 15th of September 2026. Thanks very much.
Thank you.
Yeah, I always get... I now welcome representatives from Purple House, Central Australian Aboriginal Congress and Tanangeri Council. If you'd like to come up, please. Good afternoon, everyone. Thank you so much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, I'm going to ask you each to state your full name and the capacity in which you're appearing. I'm going to start at this end of the table and we'll work our way along.
Okay, good afternoon. I'm Emmy Simpson and I work at Purple House. I'm a intake assessment for Purple House for the new beginners through to their dialysis experience with us. So yeah.
Thank you.
Hi, I'm Barbara Kimber. Work at Purple House with Emmy. Emmy's just run in, thank you. And I'm the Malpa manager, managing aged care and social support, elder care in Yuendamu, Mount Liebig and Mumbuantwa here.
Thank you.
My name is Amabella Bastida. I'm the Elder Care Support Program at Central Australian Aboriginal Congress.
Thank you.
Hi, I'm Mara Pryor. I'm the General Manager of Health Programs at Congress.
I'm Tony Corcoran. I'm the Senior Manager of Care Coordination and Support Services at Congress.
Hi, I'm Benjamin Portner. I'm the Social Services Division Manager at Tanangeri Council Aboriginal Corporation.
Great. It's really good to have you all here. I'm going to ask each of your organisations to make some short opening remarks if you would like to before we go to questions. So I might start with Purple House.
Okay, so Purple House started over 25 years ago. It's Aboriginal owned and directed. It commenced when the community of Kintor identified that their people were coming into town to get their health needs met, renal wise, but they weren't well. They were away from community, culture, family. So they did a women's and men's painting and raised over $1 million, and that's how Purple House started. And that was for the very first renal. We now have 20 renals and 10 new builds. And since then we've also expanded into what we call Malpa, which means companion in Pintabee. That was also directed by our clients. 3 women said we want to join a choir, have some fun in town, and that's what we did. So we now have aged care in Yuendamu and Mount Liebig. That was NATSIFAC funded. And up until March last year, we had the old home care packages and CHISP. And we're really successful and very proud and hopeful for a lot of other people in that we received NATSIVAC funding in Alice Springs, which was a first. So we provide support to over 200 people across 30, well, not 30, how many? So many different communities. Yeah, I've got a copy of our plan for you all as directed. So, yeah.
Thank you very much. Central Australian Aboriginal Congress.
Thank you. Thank you for inviting us to appear today at this public hearing. My name is Mara Pryor. I'm an Aranda woman born and raised here in Buntua. I'm the General Manager of Health Programs at Congress, and here with my colleagues Tony and Bella. Established more than 50 years ago, Congress is a large Aboriginal community-controlled health service delivering comprehensive primary health care to more than 17,000 people living across Central Australia. Through our Aged Care, Allied Health and Elder Care Connect program, we support older Aboriginal people to remain living safely, independently and with dignity in their homes and communities with their family and their kin. Many older Aboriginal people we work with do not want to go into residential aged care facilities unless absolutely necessary. There are challenges with the current aged care system, and we are particularly concerned that aspects of the Support at Home program limit access to timely, affordable and culturally responsive support that our clients need to be healthy and live independently at home. One of the most significant issues is the delays in assessment and the approval to access services thereafter. Across Central Australia, we have found that older Aboriginal people can wait up to roughly up to 8 weeks for their assessment and then face a waiting period of up to 12 months before their support is actually approved and provided. During this waiting period, they often end up requiring residential aged care or hospital admission as their health declines before appropriate support has been made available. These delays are particularly concerning in Central Australia, where residential aged care is constantly at capacity and with long waiting lists. As a result, older people can remain in hospital for long periods while waiting for a place at a residential aged care facility. This then contributes to the bed blocks that we see at the Alice Springs Hospital, the one hospital in Central Australia, making it a pseudo-aged care facility. Congress is also troubled about assessments being conducted by assessors who are not based in Central Australia and have no understanding of our communities, our cultural context or our service availability. Along with language barriers, these assessments occur through highly structured assessment tools that do not capture a person's real circumstances. Additionally, assessors often use AI computer scoring systems to decide what services are needed, which is deeply disappointing. Our staff have to sit in on these assessments to advocate for our clients' needs and keep assessors accountable. Without local knowledge, culturally safe support and trusted relationships, our clients' service needs can be easily missed. Human judgment and local knowledge cannot be replaced by computer-generated scoring systems. The proposed co-contribution arrangements under the Support at Home are another area of significant concern. Many older Aboriginal people living in Central Australia live on fixed and limited incomes. Even small increases in service fees can create financial hardship, and our staff have already observed clients withdrawing from services or cancelling support after receiving bills. A system intended to support independent living should not create financial barriers that discourage clients from accessing care. And lastly, Congress wishes to highlight several operational issues that affect service delivery in remote and regional areas. The current referral processes are complex and inefficient. Referrals are regularly directed to providers outside of our service catchment area. It's then nearly impossible to fix the error. To reject an accidental accepted referral requires client consent, hours on the phone with My Aged Care, which, as you can imagine, is difficult when our clients have very limited phone access, poor reception or are not in the same geographical area. These administrative requirements create unnecessary service delays and additional workloads for our staff. Accessing My Aged Care identification delays the billing and service delivery. With the absence of emergency CHISP funding, pathways for allied health services mean some older people cannot receive urgent support when it is most needed, and we respectfully urge the committee to consider providing elder care support programs with emergency funding codes for allied health which can be used in the interim while waiting for assessments. Reforms must be flexible enough to respond to the local realities and ensure equitable access regardless of where a person lives. Congress supports aged care reform that enables older Aboriginal people to live safely and independently at home, and this goal requires timely assessments, culturally safe services, affordable care and adequate investment in remote Aboriginal communities. And we thank you for your time today.
Thank you. I'm going to go to Tanangeri Council, but before I do, can you just say again for me how I pronounce your name correctly?
Like Tanangeri? Or
No,
my
your
surname?
surname.
Oh, sorry. Po'ona is
Po'ona.
Yeah, but you can say Puna, it's fine. I'm not fussed either way.
I'd like to get it right.
Thank you for asking that. Yeah, yeah, Ben's cool. Yeah, I'm fine with that.
Mr. Po'ona.
Yeah, thank you. Look, thank you for allowing Tanangeri the opportunity to have a seat at the table today to be able to discuss support at home. Tanangeri supports the purpose behind support at home, that older people should have the opportunity to remain living safely and with dignity in their homes and communities for as long as possible. Our experience tells us, however, that achieving this outcome for older Aboriginal people in Central Australia requires the aged care system to understand the circumstances in which care is actually delivered. For TACS, which is Tanangeri Aged and Community Services, providing care can mean much more than sending a worker to complete a scheduled service. It can mean finding a way to contact a client who has no working telephone. It can mean driving to a town camp community where public transport does not go. It can mean explaining an aged care budget or service agreement using audio-visual means, spoken information or an Aboriginal language. It can mean contacting a clinic because an older person has missed an appointment. It can mean finding out why a wheelchair, walker or shower chair has to be replaced 2 weeks after it was issued. It can mean helping a person whose housing conditions make the delivery of personal care difficult. And it can also mean working with family and kin before a service can successfully occur. And it can mean doing all of these things before the service that is actually funded has commenced. Tanangeri Council Aboriginal Corporation grew from the Alice Springs Town Camp movement. From the early 1970s, Aboriginal town camp residents organised to secure land, housing, water, electricity, municipal services and other basic services for their communities. Tanangeri Council was incorporated in 1979 as a service provider and umbrella organisation for the town camp housing associations. Those housing associations remain corporate members of Tanangeri Council. Tanangeri is the Aranda word meaning working together, and this remains an important description of the way our organisation operates. As an Aboriginal community controlled organisation, it has 16 town camp corporate members and more than 600 individual members. Tanangeri provides services to more than 270 individual households in the Alice Springs town camps and to more than 10,000 people across Central Australia. Our work includes aged care, community centres, tenancy support, municipal and essential services, youth services, child and family services, community safety, alcohol and other drug harm minimisation, violence prevention, employment and other community services. This matters to aged care because an older person's life does not divide neatly into government program categories. Housing affects health, transport affects access to health care, income affects food security, electricity affects whether a refrigerator, air conditioner, telephone charge or medical device can be used. Family circumstances affect care, country, culture and kinship affect well-being. TACS works within these realities every day. One of the earliest services Tanangeri Asian Community Services provided was the provision of weekend food hampers. Over time, this work developed into what is now TACS. TACS has been providing CHSP and home care home care packages to Aboriginal people for almost 45 years. Our approach has developed from working alongside the people we support. TACS provides a whole-of-life model of care that considers physical, cultural, environmental, clinical and social needs. Our services include personal care, social support, medication assistance, meals, laundry, cleaning, shopping, banking assistance, allied health and therapy, transport and advocacy. But this list does not fully describe what TACS does. In addition to food boxes, access to household goods and the provision of an on-site shop for older people, staff regularly liaise with health services such as Congress and Purple House, organise and reorganise appointments, follow up medical information and help older people navigate systems that can otherwise be difficult to access. The additional work has developed because the need exists. The term support at home has a particular meaning for Tangentyere. For the many of the people's tax supports, ageing at home means ageing within a town camp, Aboriginal community or family environment. The condition of that home matters. The people around that person matter, whether transport reaches that home, whether there is electricity, whether a worker can communicate with the older person, whether the person trusts the worker, and whether the person can contact My Aged Care, Services Australia, their clinic or other provider matters. These circumstances determine whether a service can actually be delivered successfully. They should therefore be considered part of the aged care service environment.
Thank you, Mr. Floorner. Okay, I'm going to start with Senator Ruston.
Okay, thank you. So just, can I just be clear with Purple House, is your main focus in relation to dialysis, or do you provide a broader suite of services than that?
Yeah, sorry, I thought we only had 2 minutes to introduce ourselves. That's what the scope said.
Sorry about that.
Yeah,
we're going to interrogate you.
So Purple House, our main focus is renal, keeping people on community at home with family. So we also have aged care funding. We have primary health care. We also do our Bush Brahms enterprise, which is the traditional medicine. And we also do, what else? Social support as well. So social support is for people that are more transient in and out of town, might not be eligible for aged care.
So in terms of the actual supported home program, how many of the people that you're supporting at the moment would be on an individualised supported home program?
No one, and I said that prior to here because I said we have the other experience of being successful in advocating for NATSIFAC, and we were happy to talk about the benefits of that program and how from going from CHIS to HCP funding, which is support at home now, to NATSIFAC, we can see the benefits for our clients. And that's our scope, is NATSIFAC.
So is the benefit you're saying that you're seeing for your clients driven by the fact that you can be more efficient and flexible in terms of your service delivery as an organisation that allows you to focus more on the people that you're caring for? I'm sort of keen to understand why you are able to, having moved from that system into this one.
A really simple way is that the NATSIFAC funding previously for our clients that would need to come into town for any of their healthcare need, the hospital, long-term resident, anything like that, the NATSIFAC funding boundary was pretty much Alice Springs. So then we would have to get people reassessed, which I know has now changed in once you're assessed, you're on. But they'd have to be reassessed. We'd have to wait for an assessor, a package. And then by the time they were assessed, people would be back on community again because we work with always trying to ensure we don't have enough renal chairs for everyone who needs renal. So it's a constant moving. But you also look at the NATSIFAC funding and it is around focusing on the needs and cultural space of Aboriginal and Torres Strait Islander people. So it recognises people need to move.
So I'm assuming that funding comes through as a block fund to you, and then you've got a certain set of things that you need to be able to deliver for the money that you are provided, a certain number of people
and also on what people are assessed now as needing. I think one of the benefits also is that we can start services before people are formally assessed. So prior to changing the My Aged Care Act, we could actually, given the lack of availability of assessors in remote, we could, as coordinators, like the coordinators on site, could do their own assessments in Yunnuma and Mount Liebig. Now that people need to be assessed and put onto the My Aged Care portal, that's a change for us, but we see that as a benefit in some way because then people are on the system. If they need higher levels of care, we can request that.
But in the meantime, you still have the flexibility of being able to, if you see someone you think they need care right now, you can do it.
From when we first have someone come through, no intake and assessment team, then we have 30 days from starting services to get them onto the portal.
And that funding to enable you to sort of like bridge the gap, so to speak, is coming from
NATSIFAC.
Yeah, okay.
Yeah.
Yep.
But we also, just in regards to client contributions, there is an expectation around client contributions in NATSIFAC, but each year we have the board determine if we can, we don't want anyone to miss out on services because of their financial circumstances. So the board each year makes a determination whether we will put in fees or not. And to this day we haven't, because we know that the people we work with simply are not in a position to pay client contributions.
And is that enabled by your philanthropic work and fundraising that you do outside of the funding that you're getting through NATSFAC? Or
That's all fundraising, bequests. That's, you know, that's without that real, I guess, community engagement, acknowledgement of really trying to fundraise and bequest, we would not be able to continue the way we are. And I think it's important to note, and I have already raised this with the department, for the first time, even with the NATSIFAC funding, we're reaching capacity, and we'll need to be looking at referrals to other aged care services, which is, I guess at the moment, a really different phase for us. And we're working what that might look like, because our main focus is return to country.
Yeah.
Keep people where they are. So, yeah.
Yeah, okay. And Mrs. Pryor, you made the comment around the assessment process for the people that you look after. Can you just unpack that a little bit more? Because there's been a great deal of controversy around this computer-generated algorithm that's making decisions about people's assessment and their care needs and the priority with which they get that care. Can you maybe just give us a little bit more information about your experience in terms of what that looks like for your organisation, but most particularly what that looks like for the people that are in your care?
I might actually pass this to Amabel because she actively.
So, we, with my role as Elder Care Support Program, we are just a new program that been implemented, I think, 2 years ago. And it's underfunded by NACHO and the government. So what we do is we help the elderly to engage with My Aged Care and help them with the journey throughout the My Aged Care and engage with the service provider available which area they are. So with that one, honestly, with the assessment, like you probably heard about the challenges is that we have a limited assessor in town. We have APM and ACAS who do the assessment, and APM are currently, they don't have anyone at the moment, but they are sending someone from different states to come here and do the assessment. Like maybe they stay here for a week, and then we collaborate with them and assist them looking for the client and able to sit down with the client and complete the assessment. With the ACAS, we do the same thing with them. However, sometimes they have to travel also in different area, like remote area. But yeah, with my experience with them, with the AI thing, is when it's really important that we sit down with the client, because sometimes most of our clients, they're very shy or they don't want to speak up. So our role is to make sure they tell everything to the assessor, because otherwise they won't put that on their file. So we have to make sure we are present and make sure we give them evidence that, like a summary, medical summary for the client, that client really needs, like, let's say, allied health services, because they are need of ongoing podiatry treatment because they are diabetic. So they need ongoing care. So if the client didn't tell that to the assessor won't put that on their file. And that's going to be an issue for us, because otherwise, if something happened to the client, we have to submit another referral and then they're going to do assessment, and it might take a delay for that one because we don't know the aged care assessor in town.
So is your experience since the 1st of November last year with the assessment process, are you concerned that the assessments that are being returned are not necessarily always meeting the needs of the people you care for? Is that of a concern to you?
I think it's more concerned on how they ask the question to their clients. It's not really culturally safe sometimes, because sometimes they ask questions like how their memory or something like that, that sometimes can't be used in different way. That's why we are there to make sure they not get offended on that kind of question. So I think this has been raised with the department and with the NACHO on how the assessor asks the questions and how they don't care or they're not seeing empathy on how they ask the questions, you know. And this is something that I think the elder care support program is on the road to make sure we interpret the questions properly to them. Because with our program, we have a connector who is Aboriginal, local Aboriginal, also working with us to make sure they are culturally safe during the assessment.
One of the things that we know about the integrated assessment tool is that there are a series of questions that an assessor has to ask. So is the issue the way the questions are getting asked, the actual content of the questions that the tool is requiring the assessor to ask, or both?
I think it's probably both, because if I'm not mistaken, they were also mentioned last year they're going to be a First Nation assessor. However, we don't have that one. Although we heard that the MP1 got the funding, however, they can't find anyone to do the job. And then I raised that issue to the department and to the NACHO and said why we didn't get the Congress get that invitation to apply for that one, because Congress is very qualified to be assessor, because we got a lot of Aboriginal clinicians who can do the job. But unfortunately, we are not being informed. And then when I raised that to NACHO, they said, or to the department, sorry, they said they're still waiting for the next pile, which is they don't know when.
So are there any First Nations assessors available to you at all?
No.
Also add on to Amabella's talking around. So we're funded for Care Finder through the PHN and through the NCPHN, which is a similar care connection pathway for people who don't have access to the aged care system. The assessment pulls from the WA Good Spirit, Good Life tool, and some of those questions really aren't appropriate for a stranger to be asking an Aboriginal or older person. That those questions are more suited for someone that has developed a relationship over time. So when we have assessors that do come in from interstate, there is an expectation for us as a provider to provide cultural safety training that isn't actually paid for. So I think about Amabel's time. Hannah, who's our care finder, spends a lot of time with the assessor, taking them to potential referred clients to get signed up for through My Aged Care, and they actually need that level of support, which actually isn't funded time. So I'd like to see if there's a way to incorporate that cooperation, because it's important, because I feel like we're not going to get it any other way by just leaving an assessor to go out and ask questions to people who will probably most likely not respond. And the flip side to that is when we receive the referral at the provider end, we go out to do our intake and assessment and find that there are other services that the client was probably needing but wasn't confident to be able to share because of the limited relationship that they've been able to build with the assessor.
Would the preference... So you're saying right now you need to be funded for the additional work that your services are doing to help the assessors. But would I be correct in saying, but the better approach would be to actually engage First Nations people locally who already have the skills as assessors?
The barrier is that you need to have the qualifications around it. So there's been lots of talk, I know, in the elder care circles around the elder care assessors or care doing that assessment instead of waiting for an assessor, but you need to have specific qualifications around that. Though we're all doing the work of an assessor, we would never.
I think some of it was that the department engaged APM, who's a national company.
Yes, they
to actually,
privatised it.
yeah, and look, that's where some of these issues started, because then you got people from New South Wales coming, and we've offered cultural training to some of these staff as well, because our team are finding that they were being inappropriate, and they're not going to get the assessment done, so they have to come back again. So it's not an efficient use of time either, and the assessment is not completed. So it means that people are not getting the services in a timely manner, which is not value for money.
Yep. Did you have more questions?
I just was interested to understand, like how is this actually impacting? So you're finding that with the assessment process being, flawed, that the people that you're caring for, you're struggling to be able to get the funding to be able to get the services to them. So just moreover, probably not a question to all three groups, how do you go actually being able to get access to the actual services themselves? Is it particularly difficult given the geographical sort of complexities of a lot of your delivery?
I think that's one thing that, being in Alice Spring is one thing that the resources here is very limited. And also the service provider, because at the moment we only had limited service provider for aged care. We got more NDIS provider rather than aged care. And with the Congress, with the Elder Care Support Program, we're very lucky to have a good relationship with Tanganjira, with Anglican and ARCS, so that we can directly able to monitor the client's services and able to negotiate with Tanganjira or with Anglican and ARCS the available services for them.
Sure. And is that your experience as well?
Yeah, client interactions is really quick between providers because we have those established relationships. It's just the impact to those outside of our
It's from a specific servicing of Indigenous Australians. I mean, is there scope or capacity in the market to actually find the people who are appropriate to be able to provide some of the services, because not everybody can provide every service to everybody. So in terms of actually delivering those culturally appropriate services to Indigenous Australians you care for, how hard is it to find the care workers to be able to do it?
So I'm from a broader council. So I've come from a council. We have an employment services branch within the council, and so part of what we do to encourage town camp community members into the workforce, because the remit of our council is Aboriginal people, looking after Aboriginal people. The complexities around that come with the fact that most people don't come with qualifications. So for us, we bring in people with no experience through the Indigenous Employment Initiative funding that we receive to be able to subsidise the cost of a full-time worker so we can develop the skills of a person. Our induction process goes for 3 months. It coincides with our probation period, where we do a real slow breakdown of service delivery, starting with something as simple as just providing a shopping service all the way through to assistance with medication administration. But that requires obviously a lot of mentorship and shadowing. So we have some senior workers who kind of oversee the day-to-days with our nurse who does the actual training, and then the coordinator who oversees the overall progress of a worker over time. In an ideal world, everyone would follow that process and tick, 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 there we go. But obviously, people have lives and they have family obligations. So the process does take a lot longer. So for me, it's playing the longer game by investing in community members. And if we were to have a system that allows for the building and the capacity building of our community members, because we can instill the trust to commit to the work with our existing workforce and build their capacity that way, as opposed to going, we'll go and do this training and then leaving them to their own devices and then finding that there's no supports that can kind of like help the way that a community organisation could assist with.
Can I mention we also get the IEI funding, Indigenous Employment Initiative funding. So I think all of us are very much committed to First Nations employment. What are we here for otherwise? But also with that money, again, the qualifications, we have people that have worked with old people because that's family, So it's the piece of paper then that supports that knowledge already. And we have been really successful in getting people through their Set 3 and individual support, but recognising that's IEI funding plus the Purple House Love money, that's people that are requiring, I'm trying to think of the Set 3, we had over 20 people go through it, over 16 were First Nations staff, but that was a year of Purple House giving people, 2 days off every fortnight. That's not covered by any funding. But we also want to ensure that people have opportunities as well. It might be someone's first job, return to work. I would like to take this opportunity, I bring it up every time, really concerned about the aged care worker clearance that's coming into effect. It's the same as the NDIS worker clearance, but it's got a different name. And we provided so many case studies around the barriers that was for employment. And, this requires people who have no identification. They have different names on their identification. It means as an organisation, because we want to support employment, that we will go and help people get a birth certificate, we'll help people change their name to be able to be employed by us to get a clearance. And it's just, I don't know how that supports the cultural safety that we're saying within these reforms. So
I just say that when the original bill went through, there were so many loud voices arguing exactly what you're arguing, and they were completely ignored. So I'm not surprised but disappointed that now, 8 or 9 months on, you're actually saying exactly what I know a lot of people, particularly in the witnesses that we spoke to in the Northern Territory and Northern Western Australia, said at the time. This was going to be a real challenge for you to be able to get the appropriate people to be able to work. So I'm really sorry to hear you say that, but as I say, I'm not surprised.
hoping we can, if we just keep talking about it, because sometimes it's a squeaky wheel, really. Because
Well, we can give it another crack.
give it a crack, please.
That will be good. Next time there's a bill that comes through, we will have another go. So this is all about the accord, isn't it? The employment accord, I think. Yeah. We'll have a look at it. And next time there is an amendment bill coming through, we'll see what we can do.
I might just add one last point to your original question of something that we practice at Congress, and that is bicultural pairing. So, we do recognise that the education system has failed Aboriginal people for many, many years. And we do have a lot of non-Aboriginal clinicians at Congress, but they work alongside an Aboriginal allied health assistant or an Aboriginal maternal support worker. So it's really important. It's a model that we've embedded throughout Congress, where we have bicultural pairs working in partnership. No role is higher than the other. It's a genuine partnership, Aboriginal ways of knowing, being and doing, working alongside Western medicine.
Thank you.
Which is really important.
I just want to dig down a little bit more. I tried to write down as you were all speaking, but I just want to understand which aspects of aged care source funding you're all using. So if I understand it correctly, Purple House, it's just NATSI FAC. You don't do any support at home
No.
at all. Mhm.
So,
And originally, I know that our previous witnesses went through this too, but I just want to check my understanding again. Previously, you could assess people yourselves, but now they have to go through the integrated
Yeah.
assessment tool.
yeah.
And if I understand you correctly, there are some benefits to that in getting them in the system.
I believe there's benefits to getting people onto the system because there is no residential respite facilities in Yuendamu and Mount Liebig and many, many other communities. So, yeah, well, there are some, but they're pretty full. So to be able to have people on the system versus previously we would have to get them assessed into
Yeah.
HCP, CHISP, and then have people assessed for respite or residential, and even that in itself, you know.
I guess I'm just trying to understand. So you're saying the benefit is that they're in the system then, which means if you're providing services under NATSI FAC funding and their needs increase.
We can do a referral through the portal.
Okay. But the downside is you're waiting longer for people to get assessed?
We are waiting longer, but with the beauty of NATSI FAC funding is at least we're funded still once people come to us.
Yeah.
Then we have 30 days, as I said, to get them on the system. And then I think, well, that's then not our responsibility because we've done what we need to do.
Yeah.
And if we don't have assessors available, then that's not on us.
What so you're saying you get them into the portal within 30 days?
Yep.
But does your funding flow regardless?
Yep.
Okay, that's the bit I needed to understand. So
Funding.
yeah, so then in terms of the Congress, do you provide supported home services? No.
So we are funded by NACHO for the Elder
Yep.
Care Support Program, and we have a little bucket of CHISP funding as well.
And the elder care support is like the care navigation, like Care Finder.
Care navigation, essentially navigating the system, navigating the assessment, navigating, and even after someone receives a package, Belle and her team work really hard to make sure that the clients are receiving and drawing down on that package appropriately and not being abused.
And then in terms of Tanangeri Council, you are providing support at home?
Yep. We're also funded for CHSP, the IEI, and also Care Finder. But what I will say is we're based here in Alice Springs to provide services. We're considered, I guess for a greater term, suburban. However, our model of care is not that of a delivery of care in the home because most of our old people don't have homes.
Yes, I saw your presentation at the remote
Oh,
Accord.
Yeah.
And so if I understand it correctly, you have a space that you bring people to.
Correct. Yeah. So we bring them into our day centre where we provide showers and Meals on Wheels, social support. The Arts Centre provides art therapy. Yeah. So.
Sorry, can I just add something also? With the Congress, we also, like with Mara said, that we are also providing allied health services under CHSP. But saying that with allied health services, we have only limited area that we can provide the services, that which is also difficult for our First Nation people to get services in remote area. Like for example, like for example in Hemmonsburg, Congress is not funded to give allied health services in that area. And when I'm visiting there's a lot of client needing physio, OT, podiatry on that area, and which is under the health, which is the waiting period is probably 6 to 8 months before they see the client, which is difficult for us to assist the client who needing allied health services in that area. So,
in terms of support at home, Mr. Piranha, has the move from home care packages to support at home, what's your reflections on that in terms of the services that you deliver?
I think that in terms of service provision, nothing really changed. Things went business as usual. The biggest change that we were impacted by was actually our administration. We weren't prepared, and we're still working through it. In fact, we've been requested help from the ASTAT to come and do a bit of a review of our financials, because that kind of put our reporting way behind.
Yeah.
One of the biggest changes is in aged care, I would say, for Central Australia, there really isn't a database that can actually do what we do.
Yeah.
It doesn't allow for flexibility. So we've actually tapped into using AI methods to create tools that can actually help us in a small way adapt to the changes that that Support at Home have provided, that Support at Home has come with. The other area that I think had a strong impact, but I think that's only because we've had enough practice to know that information sharing from the departments are not always culturally safe or appropriate for our region, is in our own time taking those tools and adapting them. And I've always made a point of how it's just something that constantly has to happen, because what happens up the top end doesn't relate well to people from this region. So people want to be able to see themselves. So we'll make that investment so that, one, it provides an opportunity for training our own staff to get across the changes, but also we get to integrate our clients into those conversations so they're made more aware of those. So yeah, that was probably the bigger work, was kind of getting people used to hearing what Support at Home was after they got used to CHSP and home support, after they got used to HACK from years ago.
So,
The names.
Yeah.
So in terms of co-contributions
Yeah.
for the people that you support under Support at Home,
Yeah.
are you seeing issues there?
So we've not changed the co-contributions that our clients pay. They pay $90 a fortnight, and $80 of that covers their meals. So $10 is kind of like goes to, is just really just so that we could say we're receiving something for the people that we look after. But the broader commitment from our board is to the community members themselves, and I've been fortunate that we've had some issues with where people have required more services that we can't get funding for, and in those very extreme cases we've been able to get support from the council, the broader council, to be able to assist with those.
So it seems to me that the through line from all of you is that you're doing the work to make things as culturally safe as possible, that's not being led by the government or the department. You're having to do that off your own bat, and that all of your services are also propping up the ability to deliver services either through fundraising or other avenues of funding that are not meeting the needs.
Yeah, I think I would say yes. But there are other things I mentioned before, that we have an on-site shop, and the reason we created that was because people were getting humbugged in town. I mean, that takes some time to kind of set up and administrative functions. We also do a lot of centre pay deductions to reduce the amount of cash humbug that can occur for older people, and help protect their money in that way, so that they can get food vouchers and purchase orders to obtain stuff. So there's all of these other unique types of services that don't necessarily are in view in Support at Home program, that are essential to the service delivery. Yeah.
Maybe, because I'm conscious of time, but maybe if I just give each of you an opportunity to tell us what's the key takeaway that you would like the committee to take away from you and your evidence in relation to this particular inquiry and the recommendations that we need to make.
Employ local assessors. It's not mainstream. It's not one size fits all.
Yeah.
You
and
need.
work with. Oh, sorry. I thought
Sorry,
you
go
were
on.
finished. No, yeah. I thought you were finished. Sorry.
Yeah, and I have worked with the local HOs,
Yeah.
because we've got the resources, and we've got the skill set
Yep.
to be able to do it. But don't. It's a bit of an insult, to Aboriginal people. sending someone in, from Sydney, who's got no idea of Central Australia. So let's be culturally appropriate.
And our organisations have demonstrated. We've been around, Congress 53 years. Tangentyere not long after us, and just the examples that you just gave them, that's self-determination, isn't it? Like Aboriginal community-controlled organisations see a problem and we go, okay, let's fix it, and we roll our sleeves up and we get the job done, often underfunded. But, the data shows that the Aboriginal community-controlled health organisations are the best organisations to lead this work.
The actual model of tax is a perfect one. It actually works really well, and we work very closely with tax.
Yeah, and
but there aren't enough taxes. We aren't. We could probably do it a couple more. Similar organisations that employ Indigenous people to look after their own kin.
Yeah.
That's the value in it.
Anyone else have anything they
And
want to
also probably because with the Congress, we also previously providing emergency CHSP, but they've been removed that one on us, which is difficult for our allied health team to provide services to people are in need of emergency for getting that services. So for them to get that services, they need to be assessed, which is the delayed, which is cost them like probably, I'll give you an example. Just recently, we received a referral from someone who got a wound, and by the time that the assessor assessed the client, the wound has been healed. And of course, with the Congress reputations and, dedication with helping our First Nation, they attend that one without, claiming that one on the funding. So we are probably, I would like to take this opportunity to probably think of, just bring back the emergency CHSP because of the new changes, that one's been removed. So.
Anyone else?
Maybe looking into getting emergency accommodation for some of our old patients, our clients, sorry. Mainly the ones that are sort of needing respite. Like our lot here, they all come in from out bush. So when they come in from bush, they're straight into hospital, getting onto dialysis machines and just getting the beginning of having dialysis. So it's a new thing for our countrymen that come into town. And so that's what Purple House is supporting them with, and sort of giving that, that support and making them comfortable while they're in town. So, and they look to Purple House, the one especially from where are all our places? Kirikara, Papanya, Kintor, Mount Leabig. These are the places that we've got a lot of our dialysis machine all our dialysis machines are in our Purple House are all structured out there. But when they come into town, you get the new ones that don't have any idea what to experience. So our job is to sort of give them the support and to give them accommodation too as well. They're here for a good 6 months for them to actually go through their dialysis. First of all, they have the dialysis line put in. They have to have all these appointments. They've got to be continuously doing that before they can go back to remote communities. So that's also getting that other fistula put in while they're here as well, operations, make sure that they're physically fit and healthy to go back home. But that's all the other thing too as well, making sure they've got a stable place to stay. This is what we're here at Purple House are trying to make them as comfortable. So it's a bit of a tricky one, especially when they come in from bush and they don't know anything. We've got a lot of those elderly ones, a lot of new ones. The numbers in dialysis is going up, and the ages are just going down up to about, the youngest we've got is 28 years old. So you can look at that being vulnerable person that's going to be on dialysis, and we don't know but we do know how long. It's for the rest of their lives. So that's my saying. So it'll be good to have that sort of, especially for the elderly ladies. We've got a lot of elderly clients that really need the support. And
longer term respite.
Long term respite, and that's what, because we're with Purple House is with our clients, our elderly clients, for the rest of their lives now.
Yep.
So
that's
they're
just-
really, no, that's semi. So there isn't enough accommodation. There just isn't.
No.
And yeah, that means you deliver
what we can. Yeah.
where we can. Yeah.
We do fund them for the first 2 weeks, but I know that Pat's bring them in. They fund them for about 2 weeks while they're in town, and then we take over the next 2 weeks while we do the assessment intake for them with them. Then we have to see whether they want to stay in town permanent, but they have to stay in town for the next 2 to 6 months or something like that. So depending on their health as well. So we've had a lot of clients here just stay here for over 10 years and they're still on dialysis, but they can choose to go home, but sometimes it's all up to them whether they're comfortable in getting the support in the communities as well. So it's also looking at their aged care, but we don't have dialysis all over there. Well, that's probably Sarah's dream to have it all over the place, but it's a shortage of nurses and the support and funding, all the other things come into all that as well. So
Thank you.
okay.
Mr. Bonner, anything to finish off?
I'll try to be quick. So limits is probably the biggest thing. Since 1 November, we've had just under 100 new referrals for care and services. We already look after around 154 people already, and we just don't have the capacity to be able to look after people. I've had to put a cap on meals today because we hit 100 and our kitchen just can't handle the amount. So that's one of the concerns, is that we don't actually have the building infrastructure to kind of like handle our current growth. But the other thing that I would say is, I always say that if you can get it right in the most vulnerable of places, then you'll get it right everywhere. And we've always operated under that, under a community-based model of funding. But our additional, I guess, complexity is Alice Springs is very multicultural, so we have to consider all the different cultures that we're delivering services to, and that obviously has impacts on who can work with certain people and vice versa. So I always think that people discount the or just forget that the assumptions that you base aged care or an older person on being able to receive care in the mainstream just isn't the same for us, because an older person might not have the phone, they don't have regular housing, all of these things that we don't have, that we have to navigate around before we can actually even start the care. So that's probably the thing that I'll leave with you.
All right, thank you. Can I say, sorry?
I would just really like to advocate for flexible funding.
Yes.
Easier access to assessors, culturally appropriate assessors, and recognising that not everything fits under the funding names, and that's where flexible funding is really important.
Meet the client where they're at.
Yeah.
Can I say thank you very much to all of you for taking the time? It's really clear that you have a lot of work on your plate, and for you to take time out to actually come and advocate for your organisations and the people you care for is very much valued by the committee. So the committee will be reporting to the Senate on the 24th of November 2026, and we've agreed that responses to questions on notice should be provided by close of business on Tuesday the 15th of September 2026. That actually concludes today's Support at Home hearing. So thanks again, and I'm required to say this again. Questions on notice are due by the 15th of September. We'll report on the 24th of November, and thank you to Hansard Broadcasting and the Secretariat. Thank you very much.
Thank you. Thank you.
Community Affairs References Committee's inquiry into epilepsy in Australia. I begin by acknowledging the traditional custodians of the land on which we're meeting this afternoon and pay my respects to their elders past and present. And I extend that respect to Aboriginal and Torres Strait Islander people who are here today. The committee will be conducting today's hearing via video conference and in person. Actually, it's teleconference. I'm Senator Penny Orman-Payne. I'm chair of the committee, and I have with me Senator Ruston, and joining us on the phone are Senators Antic and Ananda Raja. These are public proceedings that are being streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. And I remind committee members and witnesses who are appearing via teleconference and who are not speaking, if you could please mute your microphones. I now welcome representatives from the MPY Women's Council. Thank you very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could you please state your name and the capacity in which you're appearing today?
My name is Kim McRae, and my position is Jungu Team Manager at NPY Women's Council, which is an Aboriginal community-controlled organisation.
Great, thank you very much. I'm going to invite you to make some short opening statement and then we'll go to Senators' questions.
Sure. I'm here today because we work with people with disabilities from very remote Aboriginal communities across the NPY region, which is a 350,000 square kilometre area with 25 very remote communities. So we support people with disabilities and their families and carers. We find that I've worked at Women's Council since 2004, so I've been there a long time, and what we see with people with disability is that epilepsy can be one of the reasons that people end up in care in Alice Springs or in Port Augusta or in Kalgoorlie in WA, rather than being on country. So our work is about trying to keep people on country. We think that emotional and social well-being is linked to being on country, being with your family, speaking your own language every day, and participating in cultural activities that take place in your community on a day-to-day basis. And we see that when people end up in town in supported accommodation, often they're missing out on being with family, they're missing out on those big important events that happen out in their community. Their carers sometimes don't have a lot of knowledge about culture. All the money that is paying for their supported accommodation means that they don't get to go home very often and participate in things that matter to them. Yeah, that becomes a big issue. People get very depressed and sometimes end up either spending lots of time in the emergency department at the hospital getting very unwell, or the other thing that happens unfortunately is people get into trouble with the police because they're frustrated at not being able to get home and do the things that they want to do. But we know that families are providing the majority of the care in those remote communities because there are very few services out there. And really, the NDIS hasn't made a huge difference to that. There are still not a lot of services available for people on community. And as their care needs increase, they inevitably end up often here in Alice Springs in supported accommodation, and then there's this kind of cycle of people getting more and more either unwell or unhappy and frustrated with not being able to get home and do the things that they want.
Thank you very much. I'm going to start with Senator Nanda Raja, who's going to kick us off with questions.
Thanks, Chair. Kim, can you hear me okay?
Thank you.
So just keen to further unpack the challenges facing patients in Central Australia. I guess you're referring to adults. Can you give us a snapshot as to what happens if there are children diagnosed with epilepsy in your communities?
Yeah. It varies, but often children end up in care. They end up taken into care systems if they've got epilepsy because families have limited capacity to provide the care at home. People are living in very overcrowded housing. There is a lot of poverty in community, and there is limited access to healthcare. Even though there are clinics in a lot of the communities, those clinics are not always 100% staffed all the time. It might be 1 or 2 days a week there's a clinic sister, or the doctor might come out occasionally, but it's not an everyday. People don't have access to that sort of care every day, and also people are highly mobile. They're travelling all the time. They're going to funerals. They're participating in cultural business. They're following the football. They're coming into Alice Springs because they lost their key card, or they're having problems with their Centrelink and needing to get it sorted out. So that kind of highly mobile lifestyle makes it quite difficult to provide stable and secure and ongoing services to people.
And when you say that children are going into care, do you mean foster care?
Yep, kinship care sometimes. Sometimes child protection's involved, and children end up in the care of people other than their families. There's a range of outcomes, but yeah, often it'll be kinship care, someone else in the family providing some support for those children. But if kids have got high care needs, it's been my experience that they end up in Alice Springs.
So if they end up in Alice Springs, are they still connected to their family in some way, or are they put into a completely separate kinship group?
I think that a lot more effort is made these days to keep children connected to their family. I think there's a lot better understanding of how important that is. But we still do occasionally have families kind of lose track of their kids once they get into care because, yeah, often people don't have a phone at home and they're travelling around a lot or don't understand. They don't have English as a first language, so they'll be getting letters about what's happened with this child and not really understanding what the letter says. There can be some real difficulties, and also the costs for families of coming in and out of town from very remote communities can be quite exorbitant when they're relying on Centrelink payments. So often all of those factors contribute to families not having a huge amount of contact with kids that once they get into care.
This is a tragedy. So you're telling me because of a medical condition that they can't get access to care, these kids are basically being separated from their families and in some cases having minimal contact.
Yes, that does happen.
And would it be a case of them going into care just because of the epilepsy, or will there be other issues?
I think sometimes there's a combination of issues. That poverty is very pervasive in Central Australia. And so there can be a range of issues. Poverty, lack of education, families often struggle to understand what's required of them. Keeping people giving regular medication can be difficult when you're very transient. Just understanding what epilepsy is and how to manage it, there's a lot of education that needs to happen. And if families have got other stresses on them, like worrying about food, and if there's domestic violence in that family, if there's substance abuse or gambling issues, if the 3-bedroom house has got 16 people living in it, there can be all of those factors can contribute to the child being removed.
And if we were to switch then to the older patient, the adult, who you said would end up potentially off country and in care, how far away are these places from their homelands? Is it hundreds of kilometres away? 300, 400, 500, or?
Yep.
So
I've provided some case studies today, and in both cases, well, in all three actually, 2 of them, their families are based about 700 kilometres from Alice Springs, and one of them, the family's based about 550 kilometres from Alice Springs, so a long way.
Okay, so they would, this is pretty severe dislocation. What kind of access to neurology services do these communities have? So if they needed to see a neurologist, which you do if you have epilepsy, what is their current pathway and their access?
There's health services and clinics in communities, and my experience has been that what usually happens if someone needs to see a neurologist is they're sent into town on the doctor plane and for appointments to see the neurologist.
What is town? Is that Alice?
Alice Springs.
Or Darwin?
It can be Alice, but yeah, we also have some families that would go to Kalgoorlie or down to Port Augusta, or
And is that a regular thing? So are there clinics being run by neurologists on a regular basis or not?
I don't really have an answer to that question. I'm unsure.
Okay, no, that's all right. We have heard testimony, pretty compelling testimony backed by evidence, that care is best provided by comprehensive epilepsy centres. And these are centres usually based in hospitals with all the bells and whistles, right? Diagnostics, wraparound services, you name it. The Northern Territory is a long way away from achieving that goal. But if we aim to develop something like that, what would we need to be thinking about with respect to servicing communities in remote Australia, and what kind of cultural overlay would we need to consider?
That's a big question. I think it would be a really positive thing in Alice Springs to have access to that sort of comprehensive wraparound support for people with epilepsy and their families. I think that in remote communities, as I spoke about before, there's a big need for a lot of education because families are incredibly resilient, and it really amazes me over the years that I've worked in remote communities to see how people manage in very difficult situations. But yeah, there is definitely a need for ongoing education so families understand what epilepsy is and understand the importance of medication regime, and they also need to understand, the importance of stability for someone with epilepsy, having 3 meals a day, having your medication regularly, keeping stress levels to a minimum where you can. All of those things are really important, and I think that sometimes there are lifestyle factors that exacerbate the difficulties for people with epilepsy in remote communities. And there's also like a big, what we've identified is people feeling very ashamed about having epilepsy. And again, there needs to be much more community education so that we understand that epilepsy is part of, it's part of the normal community. Everybody, my brother, I'm a non-Aboriginal person, but I've lived all my life with a brother with epilepsy. So yeah, for me, epilepsy seems like it's very normal. But I think that there's a big education piece that needs to be done to help support people to understand, because there are incredibly resilient, amazing people who I work with every day out in communities who just need a better understanding.
If a patient needed specialist neurology access, and diagnostics, including an EEG, MRI scan, maybe some other type of scans like a SPECT scan, would they be referred to South Australia, or would they be referred to Melbourne, or is it a combination?
And that question I don't know. Yeah, don't know the answer to. That would be, I would need to speak to the clinics to be sure about that. And it might vary because we cover the tri-state area, so there may be some variation in what happens.
Generally speaking, with complex medical problems for your communities in Central Australia, in that area you were talking about, do they get referred to multiple different states, like Western Australia, South Australia, potentially Queensland?
Often they'll start off getting supported in Alice Springs, and then referrals will be made to wherever, or there may be specialists that come regularly to Alice to see people.
Yeah, okay. Are you aware of any data that's been collected on epilepsy in First Nations communities? Because we have had evidence from peak bodies like the Neurology Association and so on, who have stated clearly that epilepsy rates are double in First Nations communities. Are you aware of any local data that's been collected?
No, I'm not aware of local data that's been collected, but I have heard that stated. I mean, we have quite high levels of brain injury in remote communities. A lot of the clients that we work with, the disability clients, have a disability as a result of brain injury. Some of that is the legacy of petrol sniffing, but there's also ongoing issues with people having experienced assault, having experienced car accidents, substance abuse. Now that petrol sniffing's not a big issue, there are still other impacts.
Do you think a study would be a worthwhile thing to do, given the fact that there doesn't seem to be much data? And who would be best placed to conduct that work?
Yeah, I guess that having evidence is always useful in terms of trying to create a case for more services for people. So I would support more research and getting some real strong evidence of the need. I would, in the first instance, probably talk to Congress and the Alice Springs Hospital in terms of who would be best placed to manage that.
Okay, that's great advice. With regards to the art shows, how would the art shows fit into a future epilepsy care program? What do you think their role would be? and how do they intersect with Congress? You'll have to explain to me what the difference is and whether your roles overlap.
I work for MPY Women's Council, which is an Aboriginal community controlled organisation. We're not a health organisation, we're a community organisation. The intersection with health services is that out on the lands, the health services are providing that day-to-day care for people with disabilities. And here in Alice Springs, Congress provides a lot of the care, and the Alice Springs Hospital provides a lot of the care for people that present. So we kind of have to be highly aware of each other and work hand in hand. We're often working with the same clients and families. So that's kind of how we relate to one another. Our work, keeping people on country would be impossible without the clinics and health services that are available out there. Our work is then to look at working with the clinics and with the health services to ensure that our clients and families can stay on country.
The other question I want to ask you about is around telehealth, but let's just go back a step. What is connectivity like in these communities?
It's heaps better now than it was 22 years ago when I started working out in remote communities. It's much better than it was, but it can be inconsistent. We still have times where communities are cut off. Their telecommunications are, for whatever reason, we had a big rain over the weekend, and I think there was a big rain last night too. And so we've had messages this morning from some communities saying, everything's been cut off because of the rain. Starlink, lots of communities have access to Starlink and use that, and it's reasonably consistent. So it's much, much better now than it used to be.
Okay, and now I just want to turn to, again, a future concept, which is we've met some doctors who are intending on setting up a comprehensive epilepsy service in South Australia. And, once hopefully this is up and running, then it would potentially be a referral centre for patients in the Northern Territory, particularly in Central Australia, right? If that was to happen into the future, and I don't know when that's going to be, then with regards to patients, say children coming down, how who would accompany them? Is it I'm trying to just understand, I guess, the kinship ties and who would be the key people. Would it be both parents, one parent, sibling? Because you're talking about bringing families, children particularly, into a completely foreign environment. Inpatient stays can be 5 days, if not longer. And we would also have to think about funding potentially accommodation, or at least defraying some of those accommodation costs for patients who are referred from Central Australia. What are your thoughts?
Yeah. It varies in families. We get advice from our Aboriginal staff as to who are who's the person that needs to be coming along with that person. It's difficult because people kind of travel in family groups normally, and so to have to single out one person to be the person that is accompanying them it can be a bit of a challenge. But we work Malparara way. We work with Aboriginal staff members who will give us advice and say, that person there, sometimes it's mum, sometimes it's dad, sometimes it's grandmother, sometimes it's auntie, sometimes it's sister. There's not a one answer to that. Each family has a unique structure, or there may be kind of extenuating circumstances, which mean that you have to identify a carer within that family group.
And then accommodation-wise, is there already a setup in South Australia and Adelaide in particular for Indigenous, for First Nations patients and families who are referred there for other reasons?
We tend to use Aboriginal hostels because they're more kind of culturally appropriate. There'll be other Aboriginal people, and they're not hugely expensive. You get 3 meals a day in a hostel. Often families have got no money, or they've given their key card to someone else in the family. So they'll arrive somewhere with nothing. So when we bring people into Alice Springs for respite, for instance, our first preference is to use a hostel, because hostels are Aboriginal hostels where there's other Aboriginal people. They're locked up at night, so they're a secure environment. You're not going to be dealing with humbug from other family members in town. They're just, people feel more comfortable. Putting people in hotels and strange environments is very discombobulating and can create issues, because often you'll end up with a whole lot of other family members just land there, and it creates a whole lot of pressure for everybody.
Are you familiar with any of these hostels in Adelaide?
Yes, I am a bit familiar with some of the hostels in Adelaide, and we have used them previously when we've had clients needing to go down for extended periods, for sometimes for medical issues or other reasons.
Okay, so we might need to also, as a committee, consider whether those services would need a little bit of support, additional support. If this comprehensive centre service was set up in Adelaide.
Yep, and things like transport to and from every day. Yeah, people will need additional support around that because they don't have often. It's our experience that people just don't have access to a lot of money, and catching cabs or doing something like that is really expensive now. And so a lot of, particularly when we bring people into town, we spend a lot of time just taking people from A to B. Also, to make sure that people turn up. If you have a driver there, someone to take them, an Aboriginal person preferably, someone they feel safe with, then they're much more likely to turn up at appointments, because people get very intimidated when you take them out of what they're comfortable with.
Absolutely. I think I might leave it there, Chair, and hand it over to you. Thank you, Kim.
Thanks very much, Senator Nandaraja. You've actually covered most of the questions that I was going to ask, so I might just take a step back right to the beginning. You've talked a lot about issues with access to treatment. Mm-hmm. What are the key barriers to diagnosis of epilepsy?
Yeah, I think it's a complex question. I was thinking that with children, sometimes one of the barriers is that fear that children will be removed from the family. So families can be reluctant to present with an issue because they get worried that that child's going to be taken away. Some of it is about education. People not understanding epilepsy can take the form of absences rather than active fits, and people often don't understand what that is and need some education around that. There's a definite degree of shame where people don't like to be singled out as being different or having something wrong with them. And again, that's an education piece. That's about educating people themselves and their families that that's not something to feel ashamed about. And I think that poverty is a barrier to people being focused on health issues or when you don't have food and shelter and safety every day, often everything else is peripheral to that. That becomes the big focus. When we're dealing with families who often don't have enough food to feed the family, health issues can go, they're not prioritised because people are more worried about having their basic needs met. And that becomes a barrier to identifying that there is something that needs to be done and going ahead and doing it. And then when you stack on all those other things, there are a lot of barriers.
So, just interested in your comments about, once a young person or a person does or needs to get a diagnosis, so there's an apparent need for them to come away from where they are. One of the things that this committee looked into in Brazil, actually, Brazil about 40 years ago said we're writing into our constitution that access to healthcare is a human right. And for people who live remotely, which quite a lot do in that part of the world, they actually have facilities set up that are culturally run and safe, where, a bit like a hostel, they provide meals, but they also have on-site nurses and health staff. And we met a mother and her son at one point. He was getting cancer treatment. They'd been there for 12 months. Yep. And the government funds the cost of them to be there, so they're close to a tertiary hospital. Is that the kind of thing that is needed if First Nations people are going to truly get equitable access to healthcare off country?
Yeah, I really think that would be hugely beneficial. Yep.
Do you think it would also add to the likelihood, if we come back to the barriers to diagnosis, do you think people would be more forthcoming in seeking help for conditions if they knew that safety net was there? I
do, definitely.
Can I just ask a question? So what opportunity is there to do what Senator Orman-Bain is talking about by doing add-on to town camps? Because town camps are dry as a general rule, aren't they?
Yep.
I mean, is there an opportunity to try and build some of these sort of safe, culturally appropriate places for people to be able to access treatment for themselves or their families by working through the town camp network, or do you think it needs to be something different?
That's a big question. We use hostels because they're safer. Town camps, we have a policy of not going into town camps late in the afternoon in case there's people who may have been drinking in town camps.
So that's not...
Town camps is not a safe place for... Our experience has been for many of our clients and families that town camps are unsafe. That's why we use hostels, because of the safety aspect. I think that, there would need to be a lot of work done to ensure safety in town camps.
I'm assuming that, when I was thinking about that too, I was thinking in terms of, if you're going to look at the Brazil model, it would be things like in Adelaide, where people are having to go to get a tertiary level of care and access to specialists.
Yep.
There's a safe place that's run by First Nations people, for First Nations people, next to a tertiary.
It's like the Cancer Council, but for Indigenous
Australians. It's exactly that. Yep.
Yes.
It's probably a model that you could look at.
Definitely.
The Cancer Council do a lot of these places for rural and regional people, not necessarily Indigenous Australians, but just generally people who have to come in from country areas to have their treatments.
Yep.
And they've got it's a model that works amazingly well. It sort of seems maybe that's a place to start looking.
All right, I'm conscious of time, so can I say thanks very much, Ms McRae, for coming in and giving evidence to the committee this afternoon. It's a really important perspective for us to get in this inquiry, and I think you've surfaced some issues that the committee hasn't had the opportunity to hear about until now, so really appreciate you taking the time to come and give your evidence. The committee will report to the Senate on the 10th of September 2026. I don't think we took any questions on notice, but I'm obliged to tell you that questions on notice need to be provided by close of business on Tuesday, the 1st of September 2026. So, yeah, thanks very much. I've really found your evidence interesting and useful. I now welcome representatives from the Epilepsy Centre. Afternoon. Thanks very much for appearing before the committee today. I understand that information on parliamentary privilege and the protection and obligations of witnesses giving evidence to Senate committees has been provided to you. Could I ask you, for the benefit of the Hansard, to state your full name and the capacity in which you're appearing before us today?
So my full name is Mary Louise Holmes. I do prefer to be called Lou, and I'm a registered nurse educator with the Epilepsy Centre, SANNT.
Thank you. I'm going to invite you to make a short opening statement and then we'll go to questions.
Thank you. So first of all, thank you so much for having me today. I know that the Epilepsy Centre has already been represented in Adelaide yesterday, so I'm grateful to have this opportunity today. Much of what you have read in the NT Health submission reflects exactly what we are seeing here in the Northern Territory. NT Health has described the clinical workforce, geographic and cultural barriers facing Northern Territorians living with epilepsy. What I want to speak about is the gap that sits alongside those barriers, what happens between appointments, after diagnosis, and when a person returns to the family, school, workplace or community. I want to begin with 4 words. There is nothing here. These are the words we have heard from people and families living with epilepsy in the Northern Territory. They tell us something profound. Not simply that there are too few services, but that people do not know where to turn, who understands, or who can help them navigate life with epilepsy. NT Health itself has identified the absence of a dedicated epilepsy organisation in the Territory. NT Health has described the system gap. We are describing part of the solution. Because presence changes everything. It means a family knows where to call. It means a health professional knows where to refer. It means schools, workplace and frontline services can access epilepsy education. And it means a person living with epilepsy can hear, "You are not alone." Specialist neurology capacity in the Territory is extraordinarily stretched, particularly outside Darwin. But we cannot expect hospitals and neurologists to carry the whole burden of epilepsy. Epilepsy does not end when someone leaves the neurologist. And here in Central Australia, simply getting to a neurologist can be difficult enough. Epilepsy follows people home. It follows them to school and to work. It can affect independence, employment, relationships, mental well-being, safety and participation in community life. The fly-in, fly-out service currently being delivered are valuable and already demonstrating the need. But a 12-week outreach model alone cannot provide the continuity, relationships and trust that people and communities need over the long term. What it is showing us is that the demand is real and that the next step is to build on that investment with a sustainable, permanent presence here in the Territory. The Northern Territory does not simply need epilepsy expertise that visits, it needs epilepsy expertise that belongs here. The Epilepsy Centre has already begun building that presence here. Our team has already been working here in the Territory, providing direct support, education and advocacy. And what we have seen is clear. The demand is here. Families want support, health and community organisations want training, frontline workers want knowledge, communities want to know how to respond safely. The issue is not demand, the issue is the sustainable workforce capacity. As an epilepsy nurse, I provide specialist education and support. An epilepsy support worker can help families navigate what happens after diagnosis. A social worker can address the impact on employment, family life, mental well-being and participation in community. An educator can replace fear and misunderstanding with knowledge. Together, that workforce becomes the bridge between the health system and everyday life. We are not We are not proposing another silo. We are proposing the connective tissue. NT Health provides essential clinical care. Aboriginal community-controlled health organisations bring community-controlled, culturally safe care. What is missing is a specialist epilepsy workforce that can connect those systems with people, family, schools, workplaces and communities. And that presence must be built in partnership. For Aboriginal people and communities, epilepsy services must be developed alongside Aboriginal community-controlled health organisations, Aboriginal leaders and communities themselves. Epilepsy expertise must be local, and cultural authority must remain local. That means culturally safe education. It means trusted local relationships. It means support that works with language, culture, family and community, rather than expecting people to fit into a service model designed somewhere else. The need is particularly urgent here in the Territory. NT Health has described the disproportionate burden of epilepsy experienced by Aboriginal Territorians, the barriers to diagnosis and treatment, the challenges accessing the NDIS, the lack of culturally appropriate epilepsy education, and the enormous distances people may need to travel for care. Those problems cannot be solved by the health system alone, and they cannot be solved by a service that appears occasionally and then disappears. What is needed is sustainable investment in a locally based epilepsy workforce, including epilepsy nurses, support and navigation roles, social work, education, regional and outreach, and strong partnerships with NT Health. Aboriginal communities, Aboriginal community-controlled health organisations and communities. This is not simply about establishing an office, it is about establishing a presence that people know, a presence that health professionals can refer to, a presence that communities can trust, a presence that is still here after the hospital appointment ends. So my message to this inquiry is simple. Do not fund epilepsy services merely to visit the Northern Territory. Fund the capacity for epilepsy expertise to belong here. We are here today. What Territorians need is to know that epilepsy support will still be here tomorrow, next month and next year. We ask this committee to recommend that the Commonwealth work with the Northern Territory Government, Aboriginal community-controlled health organisations and specialist epilepsy organisations to establish sustainable, locally based epilepsy support, education and navigation capacities across the Territory. The epilepsy stands ready to be a part of that solution. We have the expertise, we have begun building the relationships, we have demonstrated the demand. What we need now is the workforce and investment to make that presence sustainable, so that no Territorian living with epilepsy ever again has to say, there is nothing here. Instead, they can say, I know where I can turn. I'm not alone. Thank you.
Thank you very much. And I'm going to go to Senator Ananda Raja to kick us off.
Thanks, Chair. Lou, I just want to turn to diagnosis firstly. So how many neurologists are there that you're aware of in the Northern Territory? We've got a submission from NT Health which says there are no resident neurologists in Central Australia, but are there any offering public services in Darwin, for example, or anywhere else?
Yes, we know of one neurologist working out of Royal Darwin Hospital.
Is that a private neurologist or a public?
He's public. He may take some private. I'm not 100% sure on that. I could get back to you on that one or take that on notice.
So we have one neurologist for around 300,000 people who live in the Northern Territory.
That's my
understanding. Are you aware of whether this person has any epilepsy subspecialization?
No, I don't think. I think he's a general neurologist, not that he has any specialty in epilepsy.
Okay. Can you tell us if you know of any neurology trainees who are interested in this field in the Northern Territory? Are there any registrars who are training up, going through the system right now who are interested in specialising in epilepsy?
Oh, no, I'm sorry. I have no knowledge of that.
Okay, all right. It's pretty hard to ask questions when we're starting off at such a low base here. I think I'm struggling a little bit. You mentioned a 12-week outreach model in your opening statement and these fly-in, fly-out teams. What were you referring to there?
So that's currently what I've been doing. I've been flying from Adelaide to Darwin every 10 to 12 weeks. I've been staying for 1 to 2 weeks and doing as much education to organisations, families, anyone wanting training in epilepsy awareness and seizure first aid. So a lot of the work I do is with schools, particularly if they have students they're supporting, or daycare centres, childcares, if they're supporting children. So we tailor the training to those children's particular seizure management plans, and we can support the staff and train them in emergency medication administration as well, midazolam. The school, everyone seems to, the minute they know I'm travelling to the territory, they're really keen to have that face-to-face training. And a lot of families as well, they often will just find our service by Googling. And when I say, well, I'll be coming up in a few weeks, if you'd like to meet with me, they just grab that opportunity. But I always say, look, if it's more urgent than that, I'm happy to, talk to you over Teams or just speak to you on the phone, which is often what we're doing also. But they just grab at that opportunity to have that face-to-face, and they're so grateful.
So when you come up to the Northern Territory, how many days do you spend up there?
My most recent visit was 2.5 weeks. That was the longest time I've been here because I did bookend it with 2 events. I was invited to the Jingley Primary School Science Health Expo. So they asked me to have a stall there and do some education with the children, which I thought was a fantastic opportunity. Working with them, they have a number of different stalls there. Lots of other organisations were there as well. And I was also, through that, I was also invited to the Waggaman Primary School Health Expo. So that was families. It was a very early morning event. Families, children and their parents came along. So there was an opportunity for education as well for family members, and other organisations other than myself were there as well. So wonderful opportunity.
Are these schools with, do they have children with epilepsy? Is that why they've reached out to you?
No, they may have, knowing that epilepsy isn't a rare condition, they possibly do have children there. In fact, beg your pardon, Jingley School have since invited me back on my next visit in November to do some training specifically for a child that will be attending school next year. So, but the Waggaman School, it was purely just a health expo that they were putting on for the community, and they'd heard I was going to be in town and were interested in having me along. So there was no specific need, particularly for that school, that I was aware of.
Could you, on notice, provide the committee with a list of the venues that you visited where you have provided education, whether they be schools or community centres? I just want to get a sense of the demand in the community. And the next question I have is, have you had any, or has NT Health, for example, reached out to you to develop a more long-term solution?
Yes. So I've had a few meetings with staff from Royal Darwin Hospital, the neurologist himself, and also the neurology nurse there. So on my last visit in May, when I was here, Darwin, I met with a neurologist, and he is he's very concerned about services here, and he wants a roundtable meeting with key organisations, particularly people that are in supported 24-hour care. He wants a roundtable meeting with these people so that we can discuss possible ways to improve services for these people that require, with epilepsy, requiring particularly those in the supported living arrangements, but just anyone in general because of the demand and the needs up here. So yes, he's very concerned. The neurology nurse herself, she talks a lot. I have spoken to her a lot about perhaps the barriers sometimes in the hospital system. So I've offered my support to both of them, saying when could they please let the families with new diagnoses, or doesn't need to be a new diagnosis, but that they're supporting families with epilepsy or individuals, let them know of our service, and I can take over, or we can take over the education that those families need, and sort of in the hope that we're lightening their burden as well, the staff burden there. But
the NT Health submission mentioned that the waiting list is 14 months to see a neurologist in the Northern Territory, and I don't know whether that's conservative or not, but with regards to neurologists, this is what it says: neurology wait lists extend up to 14 months, delaying medication titration and increasing the risk of breakthrough seizures and status epilepticus, etc. Where are these patients going if they're not waiting 14 months? Are they coming to South Australia? Are they going to Melbourne? Are they going to Brisbane? Where are the referral pathways for these patients?
yeah, so they're going everywhere. So even the Adelaide, families in Adelaide are going to Melbourne. We know of a family that went to Spain from South Australia. We're not talking South Australia right now, but other families up here I know have gone to Queensland. They're just going to places where they can get help more readily, anywhere they can turn, and they're often asking us for lists of recommendations. We only have a list for South Australia, Northern Territory. We don't have interstate. We can't sort of refer them to anyone particularly in this interstate, but I always suggest they contact the epilepsy centres in those states in the hope they might be able to help them give them some names.
There's also a comment in the NT submission about a memorandum of understanding an MOU being developed between Alice Springs Hospital and the Alfred. Are you aware of any formalised MOU arrangements between NT Health, or the hospital, either Alice or Darwin, and any of the interstate major centres, either in Adelaide, Melbourne, Brisbane, for example?
No, I'm sorry, I don't know anything about that.
Hello?
Oh, no, I'm sorry, I don't know anything.
So Mrs. Holmes said that she didn't know anything about that, Senator Anandaraja.
Okay, thanks, Chair. Can I ask you one last question? Is how do you stay up to date with your medical knowledge?
There's some fantastic resources that we refer families to as well. So the International League Against Epilepsy, they have lots of educational resources. I just attended in Darwin. I bookended my last visit with, not that this was specifically for epilepsy, but had a presence there at the conference to just let other people know that we are here in Darwin. Sorry, that's not answering your question specifically. But most of all, there's lots of webinars. There's quite a lot of education out there put on by lots of different specialists. A lot of online training. There have been the occasional seminar in Adelaide at home that I've attended. But it's a lot of what we...
Is there a formalised... Okay, no, I understand. I don't want to keep you too long. Is there a formalised, I guess, continuing medical education program for the nurses from the Epilepsy Centre?
Oh, not that I'm
because
aware
I feel
of.
it's evolving so quickly.
Yes. Can I take that one on notice and get back to you?
Yeah, of course. It may be something perhaps that the committee should consider, because there are a lot of not-for-profits just like you around this country doing this work. But I guess my question is, we need to ensure that the advice being provided has been standardised and is of high quality universally.
Yes.
I might leave it there. Thank you, Chair.
Thanks, Senator Nandaraja, and you've covered a fair bit there, but I also have had a look at the NT Health submission, and it's a shame that they aren't appearing today, because they were and now they're not. But one of the things that they say in their submission, which I would think that the NT government has control over is they talk about the fact that community awareness and advocacy are minimal, and the submission goes on to state the NT has no dedicated epilepsy organisation. And national bodies have limited local presence. And then it goes on to say this contributes to stigma, misunderstanding of seizure triggers and delayed help seeking. It would seem to me that a very easy step that the Northern Territory Government could take, given that they've acknowledged the gap, is for the Territory to fund a state or a Territory-based epilepsy organisation to do that work. Has your organisation, I mean, I know you said you've spoken to a doctor at the hospital is concerned, but to me that's different to the Territory Government itself acknowledging that they don't currently have a Territory-based organisation that can do that education and awareness work. Has your organisation had any discussions with the NT Government about funding for a service like the one you provide in South Australia that you're funded for by the South Australian Government?
I'll have to take that one on notice, but I can tell you we were here. There was a physical presence here, I think roughly 10 years ago or so.
Yes.
And
is that philanthropically funded though? I think that was the evidence we got yesterday.
Oh.
Yeah, my understanding is that any presence that's been in the NT has been funded by philanthropy.
Right.
And that the Territory Government hasn't at any point made an investment in that service.
No. I'll get back to you on notice.
Yeah, that would be good because, you know, a lot of what's in the NT Health submission is putting, as I read it, you know, they're saying they welcome all these things, but a lot of them is putting the onus and the burden back on either ARCHOs to be working to support First Nations people or the feds to be doing stuff, you know, in the hospital space. It would seem to me that that's a very easy thing that the NT Government could do to fill a gap that they themselves have acknowledged in their Health Department submission is missing.
That would be wonderful.
Can I just ask, in terms of, you made some comments earlier on about the barriers and challenges of, you know, so much demand and little ability to be able to meet that demand. Are the challenges that you're talking about just relating to, you know, the challenges of geography, of, you know, cultural appropriateness, etc., or do you have a higher number of people in the Northern Territory relatively who suffer from epilepsy?
Did you ask this question to the previous witness, something similar? Because I was thinking about how someone was asking for statistics for the Northern Territory, and I have searched and searched since I joined the Epilepsy Centre, and there's such little information out there. There is a paper based on Queensland Indigenous population, which you're probably fully aware of, and it did state that Indigenous populations do have a higher incidence of epilepsy for whatever reasons. So I don't have any. I've searched high and low for that.
So what strikes me is that if you don't actually know what the landscape is out there, it's pretty hard to start building a model of response without actually having a thorough evidence based on what to build it. And you know, if somebody is close to the coalface as you are, doesn't have that information at your fingertips, it suggests that it probably isn't known.
Yep.
So, yeah.
Certainly if the NT Health submission talks about the lack of data and that they welcome opportunities to work with the Commonwealth and research partners to strengthen the evidence base for the NT.
I wondered if Menzies could be a part of something, because I was really hoping we could get culturally appropriate resources to use up here. So I approached Menzies and they were great. They had a a healthy brain resource, and I looked at that and I contacted them saying, could we possibly develop this, like adapt it to fit epilepsy? And so the professor put me on to someone else, and we thought we'd start at the very basics and just start with a simple care plan, but designed in a way that was culturally appropriate. But it's just, again, we don't have the time for it. And I was really thinking the true experts are up here, not with us in Adelaide.
Yeah, and I mean, NT Health themselves are saying co-design of culturally adapted epilepsy education resources developed in partnership with ACHOs and Aboriginal language experts and community leaders. But again, they're saying they would welcome Commonwealth investment. So it looks like, you know, from their submission, they're looking very much to the feds to fund anything epilepsy related in the NT. I just had one other question, and that is, we heard about peer-to-peer support programs happening.
Yes.
Is that happening in the NT?
Oh, I'm so glad you asked that question. There is, in fact, you may hear from him this afternoon. So perhaps he's the best one to answer that. But I met this gentleman and his son last year when on my first trip to the Territory, and they're very, sadly, unfortunately, his son has passed away, but they're still very keen to start a support group for people with epilepsy. So, and I think it's going to be a legacy for his son. He's certainly, that's where his heart is, and we're really, really hopeful that we'll do whatever we can to support that to happen.
Yeah. So as far as you're aware, at this stage, there isn't peer-to-peer support in the NT?
Not that I'm aware of, yes.
So maybe a good place for NT government investment would be having a state-based organisation and funding some peer-to-peer support. Okay. Thank you.
That'd be wonderful. Thank you.
Thank you very much for giving your evidence this afternoon. I just need to tell you that the committee will report to the Senate on the 10th of September 2026, and we've agreed that responses to questions on notice should be provided by close of business on Tuesday, the 1st of September 2026. Thank you very much.
Thank you for having me. Thank you for the opportunity.
Yeah. Pretty shallow, isn't it?
Okay, gotcha. Yeah. I'm now going to call our next panel of witnesses together. So, Tara, and I understand that we have Reverend Halotti on the phone. So, welcome. This session is an opportunity for the committee to hear from members of the community about their lived experiences, so it will just be a listening exercise for us. We won't be asking questions. I'd like to remind everyone that this is a public hearing and these are formal proceedings of the Senate, and we'll conduct this hearing in an orderly and respectful way. More importantly, I want to remind our witnesses not to disclose any personal or private information, so not your full name, not your date of birth, not your address, or anything that you wouldn't want to be out there, because this audio is being broadcast live, and once it's out and we can't get it back. So I'm now going to welcome you both. What I'm going to ask you to do next, and I'm going to go online first and then I'll come to the table, is I'm just going to ask you to state your first name for the Hansard, or in the case of Reverend Halotti, Reverend Halotti. And it seems weird because I've just said your names, but you need to say them for the Hansard. So I'm going to go online first. So Reverend Halotti, if you could state your name, Reverend Halotti, for the Hansard.
Yeah, hi, Chair, it's Reverend Halotti here.
Thank you very much. And now to you, Tara.
My name's Tara.
Thank you very much. I'm now going to invite each of you to make your statement. I believe it's roughly around 10 minutes, so we get to hear from both of you. And I might go to Reverend Halotti online first.
Yeah, thank you to the Chair and committees, senators and those who are listening in. Thank you for the opportunity to speak to you today. As you have heard, my name is Reverend Halotti. I'm a parent and a carer speaking on behalf of my family. That we have journeyed with our sons with epilepsy for many years. And after the death of our son Smith this year in March, I'm here to ask and to present and to the inquiry to look closely at what families experience around epilepsy especially what happens after diagnosis when the condition progresses, when the systems in place trying to help families, but we see clear guidance, practical support, transport support, safety resources, and epilepsy-specific training in time for help and for protections of those who suffer from epilepsy. But today, I want to begin with a story with Simi's life, because he was not diagnosed with epilepsy from birth. And he was a young man full of life and had the future ahead of him. But unfortunately, from his age of around 14 years old, that's when he was diagnosed with epilepsy. And as he grew up, born 1992, but he grew up as an energetic baby and a loving boy, active at everything, whether it's church, school, primary school, or high school. He was a school captain, a leader, and a prefect. He was respected, confident, and hardworking. Even in his teen years, Simi demonstrated responsibility. He had goals and he had support until epilepsy changed everything for him. As I mentioned, he was first diagnosed with epilepsy towards the end of his year 10. And it came after a sporting event. And we only found out of the sporting event when his fellow other students on this retreat found him on the floor. Then we had to travel there and pick him up from the sporting event, and we took him to hospital. And from that point, epilepsy became an issue, or we were diagnosed by the doctor maybe he had a sign of epilepsy. And then from that point, epilepsy became a recurring reality. And in his year 11, he had epileptic fits twice or 3 times a year. By year 12, it increased to around 3 or 4 times. And when he went to university, there was a period of stability. He seemed to be okay with medications, but yet he still continued. And his seizures returned about 4 or 5 times a year. But despite those regular events or fits, if we say, we helped him keep going. And he finally completed a double degree in law and commerce at university. And he built a successful career in his employment. And he even married and had 2 beautiful girls. The people outside of our home, Simi appeared to be functioning well and managed well, capable, intelligent, productive. But inside our family, we were watching epilepsy affect more than his body. We were watching his mind, his emotion, and his safety start to deteriorate. We started to see changes in his mood. He became more short-tempered, more reactive, and at times wasn't thinking clearly. We also felt honestly that the pressure of family strain and relationship stress contributed to his distress. And as he continued his marriage life, we were often trying to do things during his university days and his marriage life to support him in most of his chores. But then his family didn't work out. When Simi came and stayed with us, and we continued to do our best, supporting him and supporting his 2 girls. But during this time, we noticed when he stayed with us, around 30 years old, or just before that, we start to see more of the side effects. And as a result of the side effects, because of increased medication, we start trembling, twitching hands, more pronounced mood instability. He also felt inadequate. And when we tried to prevent him from doing activities that could cause him harm, such as cooking, and when he was unsteady or playing contact sports, so he became frustrated and often ashamed of his condition. He didn't want to acknowledge his limitation. He insisted he's okay. We tried to keep it quiet, which increased our fear because we were not given the right tools or support to manage risk early and safely. And at this point in time, I started Googling and seeking help. And and then I found the epilepsy, epilepsy centre, South Australia NT, and I engaged Missy and his friends in training. I engaged Missy and his training so they understood epilepsy better. And I reached out to Epilepsy Centre SA, NT, to provide training for him and all of his friends. At this point, we started to learn more about epilepsy, and we needed structural support and for us to understand the impact on mental health and emotional well-being. We believe that the employment pressure on him played a role in what happened to him. And because of his short temper, he experienced times he struggled to think logically, with the argument that difficulty in forming coherent reasons. Over time, this contributed to him leaving his job. At his last job, his employment was terminated during his probation. From where we stand, I feel that the employers do not understand the magnitude of someone who's suffering from epilepsy, which impacts on memories, thought process, judgment, emotional regulation, and especially when medication side effects and mental health issues are worsening. So I present to the Senate inquiries and perhaps to go beyond the reactive medicine and focus on safety, communication, employment capacity, and practical support of families. In our experience, there is a lack of a clear engagement, I believe, from those who are involved. I guess not their fault, whether it's doctors or other professionals, in how family deal with someone with epilepsy. I feel that the information is not enough for us to provide to people, and which left us isolated. And I found it a very lonely journey for us. Often the person looks okay. Our son looks fine in public, but of course the full burden is not visible. And families end up carrying all the burdens, all the struggles as they try to help the person. I mean, for me, in our experience, I look at the issue of training, the first aid, basic first aid trainings for families, friends, and I feel it's probably not sufficient for families. Medication side effects, I believe that must be discussed as a central part of care, not as an afterthought. We experience serious side effects when medication doses increase, and we wish this has been addressed more clearly with guidance in monitoring, safety planning, and when urgent help is needed. And epilepsy brings mental health consequences. We observe for our son his anxiety, depression, and his emotional instability. And I think I feel that the person with epilepsy, especially our son, because in taking more and more higher dose of medication start to affect his work, perhaps through the Fair Work Act or Fair Work or industrial law, we need to look at those who are suffering from it, because as they continue in their career with more medication, start to affect their performance. And finally, there are practical barriers. I think the transport and safety equipment. Family need transport support, especially in regional rural areas where public transport, I guess, is inadequate. So people cannot reasonably attend appointment training programs for services if they cannot get there. And I feel that for us, we always have to be there available to take him and pick him up. But we understand all the help that people need for their loved one. Other things I feel that we didn't get access to are the safety products to be supplied to families where risk is recurring, not only after severe outcomes, but if seizures or seizure-related incidents occur more than once per year on a regular occasion. Perhaps families should receive appropriate safety measures and equipment as part of a proactive care plan. And I think, in conclusion, Senator, Mrs. passed away in March 2026, age 33 and 10 months. And it's a stark reminder for us of the deficiency, perhaps, of our care structure in this personal strategy. And we would like other families to be supported earlier and much more effectively going forward. And we would like epilepsy care to include community navigational services, practical safety resources, mental health support, and appropriate epilepsy trainings, and create a safe space for them for those who are suffering epilepsy. And of course, his death should not be in vain, and so as other families and other people who are going through the same journey as us. I feel there's an opportunity for us here in Northern Territory to find ways how we could recoup and come together and just to assist. And it is I have made a decision with my family and our friends and community to create a support group and continue to touch base with all the people who have been suffering from this condition, they've lost a loved one, or those who have experienced this, to come together and have peer support community group where we come together and make it happen here in Darwin.
Thank you very much.
So that's the end of my
Thank you very much, Reverend Halotti. I'm now going to go to Tara.
Thank you for enabling me to have the opportunity to speak about my lived experience today. I met lovely Reverend Halotti yesterday and his beautiful wife, so we share something. We've come to develop some visions. I just want to say that when you lose a parent, you're an orphan. When you lose a spouse, you're a widow. When you lose a child, there is nothing that describes your place. My daughter Kayla was an aspiring and accomplished sports person and student. She represented the Northern Territory in calisthenics, rugby league, rugby union. She received a scholarship in Queensland for year 12. She went from year 10 to year 12 in a scholarship with a rugby league school. That enabled her to participate in things like the Tarsha Gale Sydney Roosters summer squad, the under-18s state of origin development camps and training. She also, what did she do? Along with all of those rugby things, she also completed year 12. She was really beautiful. She was bright. She was caring. She was an influence amongst her peers. On her headstone, we actually say that being unique was her perfection, because she had such a way of bringing love to community. And that's why I'm working towards, I've been advocating since I lost her. So after she graduated year 12, she was due to turn 18. COVID struck, things changed, everybody was locked in Brisbane in the house, working, schooling. A lot of her opportunities for the interstate rugby in New South Wales sort of stopped because of the border closures. I decided to go back to Darwin. I'm born and bred from Darwin. My parents were still in Darwin, so I took my youngest son and we moved back with my two older children who had stayed in Darwin. It was after my daughter turned 18 in November of 2020 that she'd been out for a night with the friends, and they noticed that while she was asleep on the floor and they were eating pies from the servo, she had sort of stiffened up on the floor just in her sleep, and a little bit of blood sort of came out of her nose. So the mum whose house she was at, they took her to the hospital. I was in Darwin, so I started to mention to her that I think without mum being in Brisbane with you, I think you might have to consider coming home. So it was early in 2021 we started to make for her to come home. She started having, I don't even know how to describe it. I never fully saw like a seizure of what you expect from what I was taught as a young girl in school and stuff. It was like, it's the drop, the seizure, just clear the space. I didn't witness that, so we weren't too sure. She'd had a couple and attended hospitals for that. So then in late 2021, she was referred for the EEG, and in late October or early November again, she was scheduled to receive her results. So we attended the results thinking, why would they do that? You know, like she's okay, she's probably just dehydrated. She's a young girl that's gone out clubbing or whatnot. She was a nightclub promoter. And in that appointment with our one neurologist in Darwin, who was a generalised specialist, said that she had idiopathic generalised epilepsy. And we were really taken aback by that. In that same breath, he revoked her driver's licence, which was devastating to all of us because we live rural, so we're about 55 k's out of Darwin City. We don't have transport, we don't have access to services like that for her to be able to go and live her life as a young woman. She started a medication that it's one that's generally used for men, but he changed it because the one that's used for men with the generalised epilepsy, it actually makes females sterile, so he changed that. Over the coming months, she started to make complaints of waking up in night sweats. We started to notice that she was waking up with injuries, but we didn't hear anything happen, we couldn't see. She would have blank stares at you, and you could tell her eyes were flicking, or escalated stress, she would go into that zone, but it wasn't your typical seizure, what I had been taught. So we went back to the doctor, the neurologist, in March of 2022, and she mentioned that she felt like her hair was falling out and stuff, so he did us a transition of medication. And it had to be so many tablets of the old one and going to this one. In April of 2022, she actually suffered a really significant seizure at her grandmother's house. It went for 7 minutes and the ambulance was called and she was taken to the Palmerston Hospital, I think it was at the time, and they observed her for about 2.5 hours and then sent her home. I wasn't in attendance at that point, her older sister was, but as soon as she came home to me, I recognised there was a difference in my girl. So that was on a Sunday night. On the Monday, I started to ring the neurology clinic demanding, like, my daughter, something's really wrong. She's different. She looks different. She just is not her usual bright, bubbly self. Can we get an appointment, or can you arrange a referral so I can have some scans? I'd like this investigated. They'd informed me that the neurologist was away at the time, and when he returned, we would have an appointment available or made. Unfortunately, about 3 weeks later, I came home from work one afternoon. My 14-year-old son was riding his bike, helped me bring the shopping in. My phone rang. He said he was going to go for a swim. I said, grab a towel. He ran to get his phone and the towel as I was talking on the phone to an auntie from interstate. Within seconds, as he walked out, I heard a horrific scream which alerted me. I just assumed straight away a snake has bitten him. That's that pure terrified. I didn't imagine. I thought my daughter was in the room because we told her, don't go near the pool when nobody's home. As I came around the corner, my 14-year-old son had his sister draped over his body, carrying her to the edge of the pool. I had to pull her from the pool and he was screaming how blue she was, how everything. I had an elbow injury at the time, so I made it for him to call the ambulance. I commenced the CPR, but it was a bit of a period of time before anyone could really come. Because of my injuries at the time, I couldn't fully perform it, and I was saying, can I do it with my foot? What can I do? I need to... I ended up getting my son to take over, and he did it for a couple of minutes, and then the police arrived. And then just after that, it was a continuous flow of ambulance, critical response, and they worked on her from, it was like 4:40 p.m. or something till 4:44 p.m. till 5:23, which is a bit longer than what was normal. Devastating, but at the same time, since her passing, because at the time of her diagnosis we didn't have information, we weren't referred anyone, there were gaps everywhere, we knew of people, and I just recorded here that kind of presume that there's about 6 in 10 people that are Aboriginal in Darwin that have epilepsy. Of those, 4 are males, 1 child under 10, and the other one's the female, being my daughter. That's a stat that I sort of record. Of that category, 3 of those are directly related to my daughter. And one of them had passed away many years ago as well. So because we didn't understand epilepsy at diagnosis, there was not a lot happening. We did a whole lot of fundraising after that through relatives that are in the sporting industry, but we weren't sure what was directly available for the Northern Territory. So we found that money was going to the foundation in Melbourne and New South Wales, or another one over in Perth, because people were just seeing the word epilepsy and just putting it out, whatever we'd made in fundraising. Then it was later on we came across the Epilepsy Centre, and I've liaised a lot with the CEO. She's given me approvals to do fundraisers, so I've been chipping away at that since my daughter's passing. You might see the stickers that Ms O'Connor might have had that we had made. Yep. You'll see those on vehicles around Alice Springs, actually throughout Australia. That was a fundraising thing so that we could buy products to keep people engaged in Darwin. They love raffles, they love prizes, they love coming together, so we always made it purple themed and they would come together. So the selling of the stickers enabled us to purchase goods to raffle off, just to keep a steadier flow of we are here and we're trying to figure something out to make it come to Darwin. I've met Miss Holmes for the first time this year, and amazing. We've got big visions that would benefit the whole of the Northern Territory, particular Darwin. Sorry, I'm just trying to find my last bit here. In a few years to come, it would be wonderful to envision something relating to a wellness epilepsy centre based in Darwin, where people have the support. I know people that are single parents that have maybe 3 children under 10. One has epilepsy. If a seizure occurs, that parent is taking all of those children to the emergency department for an 8-hour wait. We've just come off our 6th yellow code for Royal Darwin Hospital this year, so wait times and access to any basic services. So I would like to see or become a founder of a wellness centre in honour of myself and Halotti's, our children, so that people have support, they know where to turn to, the call's there. It's not your typical chaotic emergency department, it's something a little more peaceful where the family or the diagnosed person doesn't have that elevated stress, because it's just a nice, safe place. So how I want to end that is for families like mine, knowing the Epilepsy Centre is here in the Territory, not just visiting but building a permanent presence would make a real difference. We need a trusted epilepsy service we can turn to that knows our families and understands what living with epilepsy is really like. Thank you.
Can I say to Reverend Halotti on the phone and to you, Tara, thank you for your generosity in sharing your stories. We know as a committee that that's not easy, but in doing so you're advocating for hundreds and hundreds of parents and families that have experienced the things that you have, and as a committee we really appreciate you taking the time to relive those things that are really tough and difficult for the benefit of others. And I also want to say to you that the Northern Territory Government has recognised that they need a state-based service. So I think that's a good place to start, strength to your arms in that advocacy. And it's certainly something we as a committee can see is needed in the NT. So thank you for the part that you're playing in advocating for that for other families. Thank you.
Thank you.
That concludes today's hearing. So I want to say thank you to all the witnesses who appeared and to Hansard and Broadcasting for your assistance, to the Secretariat, and the committee now the committee will report to the Senate on the 10th of September 2026. It's agreed that responses to questions on notice should be provided by close of business on Tuesday the 1st of September, and the committee stands adjourned.